I want to welcome everyone to the Silver State Health Insurance Exchange board meeting today. We're teleconferencing between the Bryan Building here in Carson City and the College of Southern Nevada in North Las Vegas. And I'm going to turn it over to Mr. Hager to do the roll call at this point. And then as members come in Las Vegas, Dr. Klein, would you make sure that we acknowledge that they're there so we can note that for the record, please?
Sure.
Director Wilden indicated he'd be absent. Commissioner Kipper? Here. Director Mullenkamp indicated he would be absent. Ms. Atkins said she'll be here in just a few minutes, and Ms. Lewis said she'd be absent. Dr. Klein?
Here.
Ms. Kerr?
Here.
Dr. Ford will arrive at 1 p.m. Ms. Johnstone?
Present.
And Chair Campbell?
Here.
We have a quorum.
Thank you. Also, again, for those in the general public that are participating in this meeting, we will have public comment at the beginning of the meeting and at the end of the meeting. I will not be calling for general comment during the meeting except for the regulatory workshop process. And public comment will be limited to 3 minutes per person. So with that, I'll open up agenda item number 2, which is public comment. Do we have anyone in Las Vegas that would like to participate?
I see no public comment, and Ms. Atkins has joined us.
For the record, John Hager, so we have received 4 comments that have been posted to our website, public comment 1 through 4. The first one is from Christine Caulfield with Access to Healthcare Network. The second one is from Delta Dental. One thing I'd like to point out for Delta Dental is in order to allow the exchange to offer plans on the exchange that do not include dental, we have to have a standalone dental product. This letter from Delta Dental indicates that they intend to provide a standalone dental product, assuming that we continue to go forward in the same manner that we have been going forward, a low regulatory, business-friendly environment. So this helps us. It helps the carriers understand better what they need to provide. And so that letter is actually a very important letter, allowing us to offer, indicating that Delta Dental will offer standalone dental, and that means that the qualified health plans are not required to offer an embedded dental plan. The third public comment is from the Immune Deficiency Foundation, and the fourth is from Dan Heffley and a group of underwriters, brokers from the National Association of Health Underwriters and the Nevada Association of Health Underwriters, Northern Nevada and Clark County groups, and then from Trey Abney with the Chamber of Reno and Sparks in Northern Nevada.
Thank you, Mr. Hager. Dr. Klein, did you say that there was no one for public comment in Las Vegas?
See no public comment, no.
Thank you. Anyone here in Carson City?
This thing.
Okay. Thank you to the Silver State Health Insurance Board of Directors for the good work that you're doing on behalf of all Nevadans and the future of healthcare in our state. My name is Al Schubert. I'm speaking on behalf of VSP Vision Care. VSP is on the record previously as one of the largest insurers by membership in the state of Nevada. We cover 1 in 4 of all Nevadans today, 26.3%. Moreover, 90% of those covered in Nevada today for vision care, as you may know, obtain their vision care through standalone vision plans. So only 10% of vision care is delivered by a health plan presently in the state. We appreciate and thank you for recognizing the vital role of standalone vision plans previously, but my purpose today is to comment on an issue that's been recently called to our attention with respect to the Nevada revised statutes, specifically for the record, Statute 695I.210, that appears to not allow standalone vision plans and standalone dental plans to participate in the Silver State Health Insurance Exchange, even as supplemental offerings. VSP and the standalone vision care industry hereby go on record in support of a bill draft request to correct this issue. And we believe it important to all Nevadans and to the ultimate delivery system. Moreover, we believe that it's important to protect the revenue source derived from fees charged for products offered in the exchange, which is the primary purpose for this meeting today. Thank you very much.
Thank you.
Could you press the button in front?
Sure.
Turn it off.
Thank you. Any other public comment here in Carson? All right, do we have any public comment from people participating on the telephone? All right, sounds like we do not. So I'm going to close agenda item number 2, and we'll move on to the approval of the minutes from November 8th, 2012. Do we have any additions, amendments, or changes to those minutes? Okay, I think the only thing that we need to correct on the minutes is under the staff members assisting for Dennis Belcourt. That probably should be Deputy Attorney General or Senior Deputy Attorney General instead of General Counsel. So with that one amendment, do we have a motion to approve?
Marie Kerr, motion to approve.
Lynn Atkins, second.
Thank you, Ms. Atkins. All right. All in favor of the motion?
Aye. Aye.
All right, thank you. Motion passes. Now we will open up agenda item number 4, which is to conduct the workshop on the first of the regulations that the Health Insurance Exchange will be adopting. And with that, I'm going to turn it over to our Executive Director to walk us through the process that we've already taken and where we are right now.
For the record, John Hager. So our previous workshop in November looked at one option. These two options grew out of the discussion from that meeting. There was discussion about how to charge standalone vision products and the various variations, and because of that, we provided a simple option that was a direct, I guess, child of the previous regulation we discussed. And then option 2 was a more complicated version that included the various options of qualified health plans with dental, with vision, with dental without vision, without dental, with vision, etc. In reviewing the statutes, again, for probably the 100th time, we noticed that there was a section in the statute, NRS 695I-210, that indicated that the exchange can only provide qualified health plans. As you heard in the testimony, dental and vision plans are not qualified health plans, so there's an issue there. One of the sections of our statute allows the exchange, or requires that the exchange implement all aspects of the Affordable Care Act, and one of those aspects is allowing a standalone dental program. So in reality, the federal rules and regulations, statutes and regulations, require that we offer both a qualified health plans, and standalone dental plans. However, there is no such authority in the statute to offer standalone vision plans. It's kind of a kink in the whole thing. So while there is an exception for dental, and it requires that we allow dental plans be offered on the exchange, it does not provide that for vision plans. It doesn't say yes or no. The problem is that we have a state statute that says you can't provide it. Because of that, it's I don't know if it's quite right to include in a regulation a requirement for a fee for a vision plan if we don't have the authorization to do that. I think the board has been very clear in its policies to offer standalone vision products along with dental products, and so we intend to include an amendment to our BDR to allow the vision plan, but without that change in statute, we really can't create a regulation that conflicts with the statute. So what staff has done, and we've looked at the regulation. Option 1 is the closest to that, to what we need. The only thing is that we have to eliminate the section about standalone contracts for vision insurance. So backing up a little bit, we discussed the background for the need at the last meeting for this regulation. We talked about how the exchange expects to charge fees to carriers, that the carriers have been expecting this now for quite a while, that we have a need to create a regulation that sets a process to create those fees, and so this regulation sets that process. We also discussed having an adoption hearing for this regulation in January and then moving into the rate setting so that we would allow the carriers to have a firm understanding of what their rates will be going forward, and that will allow them to start setting rates to submit to the Division of Insurance for plan certification and rate review. The cost impacts, we did a small business impact statement, and while this raises fees and costs small businesses a certain amount, about 2 weeks ago, I think, the CMS issued regulations that indicated that the federally facilitated exchange would charge 3.5% of premium to use the federally facilitated exchange. That is more than the rates that we are charging. We estimate that that's about $3.2 million a year more than what we are expecting to charge. So while there is an impact to business, while the exchange, the services provided by the exchange will cost carriers, and that cost will be passed on to small businesses, we expect that cost will actually be less than if the state decided to go forward with a federally facilitated exchange instead of a state-based exchange. So you could actually view it as a savings compared to the alternative of letting the feds do it. So going through the regulation, we don't have anything really to add to option 1, but if you are on option 1 on page 2, we would strike paragraph D of subsection 2, the line that says standalone contracts of vision insurance. It's staff's recommendation to strike that line, and so then we would move the "and" in the previous paragraph from paragraph C to paragraph B, because the list is 3 instead of 4. And then the next line on subsection 3, we would change it to read, basically change it from plural to singular. The fees charged for the type of contracts of insurance provided in paragraph C of subsection 2, striking the reference to subsection D. An exact replica of that change would also occur for section 6, striking the references to the vision insurance. And with that, I'll be happy to take any questions. Is that Ms. Lewis here?
Oh, yes.
Please
I'm
note
sorry,
for
I
the
failed in
record
my task. I'm sorry, I failed in my task.
Please note
Thank
for the
you.
record that Ms. Lewis is here.
Mr. Hager, I think
We've lost you. We can't hear you.
Sorry, thank you. I was just asking Mr. Hager if he would just do a comparison between option 1 and option 2. And I think what it is it's calling out, it's in that section 2 that we were amending anyway.
For the record, John Hager. So yes, option 2 included the various iterations of whether a qualified health plan has vision or dental, or if it's standalone. So you'll notice that if you're looking at page 2 of option 2, you'll see that there are 6 different types of plans. Qualified health plans that include both dental and vision, plans that don't include either plans that include one or the other, and then the standalone products because of our and realize that these two options were posted about 16 days ago, and we noticed about 5 days ago the conflict with the statute. So because of that, there's no other difference between option 1 and option 2, and because we think that we need to eliminate the references to vision, that reduces that to 3 options that you see on page 2 of option 1, which are qualified health plans that do not include dental coverage, qualified health plans that include dental coverage, and standalone dental plans.
John, if assuming this BDR that we heard about is passed in a few months, will you then have to readopt different regulations again?
For the record, John Hager, yes, we would submit to the board for adoption basically the original language. We would add the various iterations, and so the way we have this written here, it would allow us to easily add those extra items.
All right.
Voice, we lost you again.
Oh, okay. I'm not pressing the button hard enough. I'm sorry. With respect to the 2 different options, the only difference is in that subsection 2.
I should note that it's in subsection 2 and then subsection 3. Subsection 3 talks about how to combine the various fees,
Okay.
but they are related.
Okay. All right, so let's open it up for public comment, and then we'll open it up for discussion among board members after that comment. Anybody in Las Vegas that would like to comment on the proposed regulation?
I see none.
How about here in Carson City? Okay, how about on the telephone? All right, so I guess the discussion among board members would be then which version would be the best as far as delineating the administration of this regulation.
This is Marie Kerr. I want to thank the staff for putting the time in to clarify and make the changes. It looks like a lot of work was put into drafting the reg during the month that we haven't met. Can I tell you, before we vote, what my opinion is? Sure. My opinion is it makes the most sense to adopt option 1 with the changes stated. And then after a successful BDR process in which we get changes to NRS 695I 210B, then we adopt option 2, which is wonderfully clear and sets forth all the different, I ran through a logic path, and it sets forth all the different options that Ms. Johnstone mentioned last time were a problem that we weren't putting together. It gives the insurers the most flexibility to give different types of plans that people might want to take on. So that's my opinion.
Thank you. Any other comments from board members? All right. There being none, is any board member desirous of making a motion for adoption of option number?
Not adoption.
No.
2.
Yeah. Sorry.
Usually you don't take any kind of motions during a public workshop, even though it's agendized that you can take action. It's more an informational setting. So
Okay.
you take that and you take Marie's comments, and then I think you just simply need to move forward at the public adoption hearing in January with those options. But you don't really need to take any action.
All right. Thank you. I appreciate the clarity on that. I'm used to having a full board at an adoption hearing, not at a workshop, so thank you for catching me on that.
Okay.
All right. Are there any other comments from board members regarding option number 1 or option number 2?
For the record, John Hager. So then it is staff's intent to go forward with option 1 with the changes that we've proposed. It appears that that's the direction that we want to take. For the adoption hearing January 10th. The 30-day notice was 2 days ago for the adoption hearing, so we're going to amend the notice. The only amendment will be the section referring to the final regs to appear at that adoption hearing. So we'll provide the public with the adjusted, we'll call it option 1B, so that we'll have specific language to adopt at the hearing on January.
All right. If there aren't any other edits or comments on this, I'm going to close agenda item number 4. And just so that the public again knows, January 10th would be the adoption hearing of the regulation by the board. So moving on to agenda item number 5, it's our executive director's report.
For the record, John Hager, the report in item number 5 goes through, as we have been in the last several board meetings, the status of exchange implementation, advisory committees, the status of contracts, and the board calendar. This one also includes a reminder to file a financial disclosure and various items, more detail regarding the implementation. So I think it was this past May the board approved the bylaws that said that every year the board would file financial disclosures. That disclosure is supposed to be filed with the Secretary of State on the Secretary of State's website. We've been told that we can expect it, that the new filing period will be open sometime on or about December 15th. So hopefully after this weekend you should be able to go onto the Secretary of State's website and file a disclosure for calendar year 2012. Right now you can only see calendar year 2011, which doesn't help us out a whole lot. They would prefer it if we waited until January 1st to do this disclosure. It has to be done by January 15th. So just note that if you do it before January 1st, if there is any change in your financial disclosure status, if you come across some additional revenue source that should be disclosed, make sure you do so. You amend that disclosure. So the website is the link at the bottom of that paragraph, and you'll have to create a login to get onto that.
John, can I ask a question, please? I'm sorry.
Please.
Lynette Kinsberger, could I be so indulgent to ask if maybe staff could send a reminder to the board members on January 2nd or 3rd with that link for us to do that?
Athena is nodding her head yes.
Thank you.
And I'm nodding my head yes as well. So the board, we've had a slight change in the board. You may have seen the notice that Terry Johnson was appointed to the Gaming Control Board. Director Bruce Breslow was appointed in his place. The sections regarding the non-voting ex officio members are the Director of Business and Industry Administration and Health and Human Services, or their appointees. And so Director Bruce Breslow has appointed Commissioner Kipper as our board member. So welcome, Commissioner Kipper.
Thank you. It's a privilege to serve with you all, and I'm certainly looking forward to a productive turn here at on the board.
And not that he hasn't been to nearly every board meeting anyways, but he's now officially on the board. So at the Exchange, we have hired a new finance and research, it should be officer, not office, finance and research officer. His name is Damon Haycock. He's coming from the division, or from the health division at the Department of Health and Human Services, and he'll start with us on Monday. And we are currently in the process of recruiting our IT analyst, which should begin work on or about probably January 2nd, since nobody else is going to be working on January 1st. And then one other update I thought it'd be interesting to note. Several of us at the Exchange staff are going to be pursuing broker licenses with the Division of Insurance. Going through the training, we will get the license and then freeze it as in a similar manner to what the Division of Insurance staff does, so that there's no conflicts of interest. But we feel it's important that we have a better understanding of the training requirements of brokers to help us mold the training requirements for the navigators and enrollment assisters. and we'll discuss those in more detail, I think, in agenda item number 10. We have been onslaughted with a ton of federal regulations. You can see them all listed on page 3 and 4. Hundreds of pages of regulations. We're going through those. The Division of Insurance is going through those. We plan on submitting comments to CMS. It doesn't appear to change a whole lot. There are some details that are changed, and so we're working through that to figure out what those changes are and how they impact Nevada. And again, we'll provide those comments as they come due. And then again, the reference to the federally facilitated exchange charging a 3.5% fee. And we're estimating about a $3.2 million savings compared to the federally facilitated exchange. It's actually greater the first couple years. The $3.2 million is a long-term savings based on the current enrollment estimates. One thing I would like to add, though, you may have heard on Tuesday the governor announced that that he intends to propose in his budget that the state of Nevada expand Medicaid eligibility. What that means is that eligibility will include anybody almost everybody, up to and including 138% of the federal poverty level. So it's about $20,000 for an individual. That means that our enrollment, we have been assuming that our enrollment went down to 100% of the federal poverty level. That lower threshold for eligibility for the advanced premium tax credit now goes up from 100% to 138%. And so our enrollment will actually go down because that section of our population will actually be under Medicaid instead of us. That means that our fixed costs are distributed among a smaller group of people, which means that our per member per month fee will go up slightly. If you're interested to see the difference, you can look at our finance sustainability plan that is on the About page on our website, so exchange.nv.gov, and select About, and at the bottom you'll see the finance and sustainability plan. It has both options shown there, so you can see the difference. Those rates are not exact rates. We will be including all of the changes that we've made to the budget over the last couple of months, the policy decisions that the board has made, and put those into some published rates that will be published in the next couple of weeks for everybody to see. But you will notice that they will go up very slightly, maybe 25-50 cents. So upcoming deadlines, the declaration from the governor is due tomorrow. The blueprint is also due tomorrow, though we have submitted that. It was submitted back on November 16th. We would expect to have probably a conditional certification by January 1st from the Secretary of Health and Human Services. And then we go into legislative session. Go live is 292 days away, and those days are counting down very quickly. And then our first date of coverage is January 1st of 2014. You'll see in agenda item number 10 that the advisory committees have made 30 substantial recommendations to the board, of which the board has approved 23, and this agenda will discuss 6 of them. Let's see, we discussed the workshop already and the legislative session that's beginning, and once we have a firmer understanding of all of the requirements that we'll need for the BDR, we are going to include in our BDR request all of the policy decisions that the board has made. Most of it has already been seen by the board, and we will provide those, the final BDR draft to the board probably at the January meeting. But as you can imagine, we come across things every day, such as this issue with the vision plans that affects not only vision but also affects our ability to offer perhaps an HSA or HRA or other products. And so we'll get that to the board as soon as we can. The technical implementation, we have completed our first of 3 requirements and configuration sessions, or RAC sessions, with Xerox. Those RAC sessions basically take our business requirements and make sure that Xerox understands them properly so that they can translate them into the bits and bytes of the web portal. We are going to move into RAC Session B in January, probably from January through early February, and then RAC Session C will probably be around March. Meanwhile, we are working with them at least on a weekly basis, even between the RAC sessions, but usually on a daily basis for all the different components, including navigator training, including all the different things that you might think we might need to include. The advisory committees, as we noted in the past, the finance and sustainability and the shop committees are done with their work unless the committee submits a new item for discussion with them. Plan certification and risk and reinsurance, we intend to have committee meetings in January. I think we actually set one of those meetings, the plan certification meeting has been set, and so the committee members should have the date for that. And then the Consumer Assistance Committee, I believe, has also been set in February. We just set those today. That's why they're TBD here. After that, we're not sure how many more committee meetings we'll have. Those might be the last of them. Cross your fingers, right? And that then means that the policy decisions of the board we're going into finishing up the regulatory process, getting through session, and pure implementation after that. I'm not going to make any promises on when we intend to stop meeting monthly, because the last time I said this was going to be a phone meeting, this has turned out to be a 5-hour meeting, but we're moving ahead. The status of the contracts, you can see them on page 7. The latest addition is the Marketing and Outreach Services vendor KPS3, which we'll talk at the ratification discussion, which I think is next. For an estimated ratification of today, execution by the Board of Examiners, approval by the Board of Examiners is expected on the 8th of January, and that contract goes through December of 2014. And then the calendar is here as well. With that, I'll be happy to take any questions.
Do any of the board members have questions for Mr. Hager? All right, thank you for your very comprehensive report. We'll move to agenda item number 6, which is possible action regarding the ratification for the marketing and outreach vendor selection, which was our request for proposal 3006. And Ms. DeBruce, I think you're going to take over on that one for us.
I am. Thank you. As we have discussed in the past, this particular RFP followed the same processes and procedures through the State of Nevada Purchasing Division. The RFP was issued on September 21st, and we received 8 different proposals. The exchange was looking for a marketing and outreach project, a plan returned in the proposals that would encompass 3 different phases that would include planning, an education campaign, and a call to action. We expected that the start date for the planning phase would be approximately January 14th or towards the end of January. We thought that the goals and the tasks would be identified between the staff and the vendor, and that we were looking for options for branding of the exchange and branding of the web portal, and ideas about how we can reach our target population. The education campaign that we thought would start approximately in February, the goals there would be to design a marketing and outreach campaign aimed at reaching all of our target audiences in a culturally and linguistically appropriate approach. And we were looking for, again, ideas and the methodology that they would use in their proposed media campaigns, and the amount of funding that they would put towards commercials either on TV or on radio, or their different avenues and the way that they would approach that. Phase 3, the call to action, that would be starting June 1st. This is where we start telling people, it's coming, get ready, we want to sign up, you want to go to our web portal or call this number. So I think that we got very good proposals. As in the past, we looked at demonstrated competence, how they had done similar proposals in the past, looked at how they conformed with the terms of the RFP. Did they follow the instructions that we set forth for them? We looked at their key personnel. Do they have the staff? Can they do this? Do they have the expertise and the education to perform these duties for us? We looked at their references, and I must say that these were some of the best references that I had ever seen on an RFP and on RFP responses. We looked at the cost and the financial stability of the companies and their ability to perform this throughout the entire life of the project. So on November 1st, as I said, we received 8 proposals, and then we met. We had Department of Health and Human Services Director's Office personnel. We had exchange staff, and we had one non-state participant who were doing the evaluations. And we scored KPS 3 as the highest scoring vendor. And we felt that they really understood the barriers of enrolling our target audience in Nevada and the difficulties that we would face with these. This is a hard sell. We felt that they had a subcontractor, Access to Healthcare, who was bringing an excellent list of community partners, and that would help us reach our target audiences. We liked their cost proposal and how they said that they did not inflate their media buys and they were passing on those direct costs to the exchange. Their sample print media was engaging. We felt that they had experience with rebranding healthcare organizations and that they were a local Nevada producer and that they would really know Nevada and how to reach our audience. So the effective date of the contract would be January 8th, as John said, at the BOE meeting, through March 31st of 2014. The contract is set and written not to exceed $6 million. And this contract will be performed, the duties of the contract will be performed as the other contracts that we've done in the past, where it would be done on a work order basis. So we will have very fine-tuned control of each aspect of this contract and be able to really quantify the results that we get and measure them as we go along. And that's the end of my report.
Thank you, Shauna. Do we have any questions for Shauna on the contract? Yes.
Leslie Johnston for the record. I just have some questions on the types of proposals that you received, and there are 3 of them. So the first question is, of the 8 proposals that we received, what was the range in the cost proposals that we received? The second question is, of this maximum $6 million, what was their estimate, percentage or dollars, of how much of that should be on media buys themselves? Mm-hmm. And then the third question is, how much of that up to $6 million was thought to be needed through the first open enrollment period?
Okay, so the first question is the range of costs from all 8 proposals. And I don't have those numbers exactly in front of me, but as I recall, it was a very wide range. It ranged from about $1 million all the way up to over $7.2 million. So it was a very, very wide range. One of the things, and this leads into your second question, one of the things that we did in order to try to compare apples to apples is to compare $1 million versus a $7.2 million is very difficult. So we did look at the percentage of media buy. You know, if they're both 50%, then you can kind of say that that might be similar. But in the KPS 3, they did have the highest percentage. It was over $3.5 million that they expected, that they had proposed to purchase media. And their initial contract, I must say, was a little bit higher, the proposal, and we negotiated them to the $6 million. So, but on a percentage basis, they had the highest percentage basis of media buys for the total contract cost. Okay, and then the third question, I'm sorry?
Roughly the percentage of the total that they thought they needed through the first open enrollment period.
Oh, so through March, so the contract is through March 14 of 2014. So this contract goes through the first open enrollment period.
The question's not relevant. Okay. Thank you.
Do any other?
Madam Chairman, LaVon.
Yes, Ms. Lewis.
LaVon Lewis in Las Vegas. Well, I would be interested in knowing, did you get any bids from any minority contractors? And 2, what percentage or what discussion was held in the proposals as to how they are going to particularly reach the Hispanic and other minority communities? Or was there any discussion of that in the proposals?
Again, off the top of my head, we had one vendor that had a subcontractor that was a minority contractor, and it was a tribal organization. None of the primary contractors that put forth proposals would be considered a minority organization. We all paid special attention to how each of the vendors proposed to meet the needs of the minorities in Nevada, whether that was the Spanish-speaking community or the tribal organizations. And KPS3, in addition to several of them, but KPS3 definitely paid very good attention to that. And with the community partners that they have, especially with access to healthcare, they can bring the Spanish-speaking and tribal liaisons to the table and make sure that we are reaching out to them in the best way possible.
Ron Klein, can you enlighten me as to how much experience this company has in working in Southern Nevada? Since it's, I guess if I understand correctly, it's a Northern Nevada-based company.
Dr. Klein, the company is in Reno. Access to Healthcare Network has offices in Las Vegas area, and they are definitely relying on that partnership to bring the Southern Nevada experience into play here. As to their experience, I can the contract, the proposal went public yesterday, so I can share with you. I can forward you some information about their company and some of the other programs and campaigns that they have worked on that were included in that proposal, but I do not have that information with me at this time.
My understanding is that Access to Healthcare is primarily a Northern Nevada-based program, although they have recently made some inroads here, so I'm not sure if that really qualifies as having a lot of experience in Southern Nevada.
My understanding is that they have a staff of 13 in Las Vegas and that they have been established there for some time. I can find out those exact dates for you.
Yeah, if you would. I think they're relatively recent to the area, I think.
Okay.
Lynn Atkins, for the record, a follow-up question. Is KPS3, is the only agency they're subcontracting with Access to Healthcare?
Yes, ma'am. That is their only subcontractor.
And I guess I had initially assumed, that they were going to subcontract with a marketing, PR, or advertising firm. Access to Healthcare is not a PR, advertising, or marketing company. Is that right?
That is correct. KPS3 is a marketing company. And they are partnering with Access to Healthcare so that they can reach out into those partner communities and the partner organizations that they have throughout Nevada in order just to get the message out further and in the proper formats. It's to provide.
Go ahead. I'm sorry.
I was going to say that they will help them provide the expertise to know what that message is and how it should go out and who it should be reached out to.
I guess I'm having a problem conceptualizing it because Access to Healthcare Network, they're a private nonprofit organization that markets their own healthcare program, right? It's like a fee-for-service program. Sliding scale. So I guess I'm having a problem conceptualizing the partnership and the subcontracting, and is Access to Healthcare Network going to stop doing what they're doing, or I might be completely confused, and I apologize.
No, I believe your thought process is right on. They do have that as part of their organization. I think that they don't plan on stopping their current processes. They are a subcontractor of KPS3. They are there to provide expertise to the communities, to provide some guidance as to how to reach out to these people, because that's where their expertise lies. They have partnerships. The marketing, the PR, the advertising, that expertise lies within KPS3. They will reach out. They have the people on staff that will reach out, that will buy the media, that will create the campaign. The expertise that Access to Healthcare Network brings is the expertise in our outlying communities and how to reach to Nevada citizens.
I'm sorry, Madam Chairman Lavon Lewis. I really don't understand. Are you saying that access to health care is going to be part of this marketing process? Or will they be marketing their own organization as one organization that people can come to? Or what just is going to be their role? Because I don't, well, perhaps they were able to demonstrate in the proposal that they had some particular inroads into the community in Southern Nevada, but that's not how I perceive them. So what's going to be their role? If they're going to continue to have their fee-for-service on a sliding scale that they offer, then what are they going to do in the marketing environment that's going to get the word out about enrolling in the affordable care program that we're going to have, that's going to be different? What's going to be their role?
For the record, John Hager. So the primary responsibility for the marketing and advertising will fall on KPS3. KPS3 will create the holistic, comprehensive media plan. They will purchase the television time, the radio time, the billboards, the print, the coffee sleeves, whatever else that might be needed. What I believe Access to Healthcare Network provides is some boots on the ground. Those groups that don't necessarily aren't overly exposed to television, to radio, or maybe aren't overly exposed to certain locations where our billboards might be, what have you. They'll be able to have the boots on the ground going from location to location. I don't know if that's door to door, or I don't know exactly how it works, but they will actually be meeting in person with individuals. From my understanding, that's how that part of the campaign is supposed to run. So they are providing the ability to actually get to some of those harder to reach individuals with more face-to-face communication.
We may be a little slow down here in Southern Nevada, but all three board members down here are confused. Again, I believe I gave Access to Healthcare an award 2 years ago when I was the State Medical Association president, because of the fine work they've done in Northern Nevada. And I believe, sitting on the County Medical Association board here, I believe that they've made one or two presentations, but I think their presence here is relatively small. I certainly don't encounter them on any kind of frequent basis. And the problem that we're all having here, because we're all sitting here talking to each other, is this is an organization that helps gain people access to health care by, the way I understand it, working with physicians for people to accept a sliding scale program. So we don't understand how they are part of a marketing effort. And if they're not, then the next question is, what experience does KPS3 have in the Southern Nevada market, where 3/4 of the population of Nevada is? I think that's what we're coming back to.
You know what, if I might, we have someone here in Carson City that was part of the RFP process, and I believe sat on the committee, and might be able to give us some insight. So if you could identify yourself for the record, please.
Okay. My name is Amber Joyner. I'm Director of Government Relations for the Nevada State Medical Association. I was just hoping to offer a little bit of clarification of what my understanding was when I was serving on this committee. The Access to Healthcare Network, my understanding, the question was, if they have their current product, how are they going to be advertising our exchange product? My understanding is that largely their current client base is going to be entirely turned over. They're going to end up with insurance. So in my mind, the concept was they already have relationships with this uninsured population, and while they are sending out their messages about, in the next 12 months, here are some ways you can access care, they will also be pushing out information about, here's the exchange and here's how you can get insurance, either through now the Medicaid expansion, which many of them will qualify for, or through the subsidies that are going to be in the exchange. And so in my mind, I thought it was a perfect relationship to help these people transition from this uninsured population who's getting discounted services right now, that at the same time they're receiving that communication, they're receiving information about how to enroll in insurance. So I think for me that was the way that it's going to interface.
Amber, how much of a presence do they have down? I mean, I'm just not. I mean, I've heard them speak a couple times, but I'm not aware of them having a large presence in Southern Nevada. Are you aware of that, or?
I'm only aware of what was presented I mean, obviously I know Access to Healthcare Network up here in the north. What was presented in the proposal, the two pieces that I thought covered Southern Nevada well is that many of their partners, they had over 40 listed in the proposal, are statewide. I mean, they listed banks, Walmart, places that they already have a contact, a channel, and now the message would just need to be changed to be put out into the community. So I felt like those connections were with large enough companies that it did cover Southern Nevada. The other main component is the door-to-door that they proposed, which I thought was really unique and really necessary that none of the other proposals had. And that door-to-door campaign will be in the South. And so again, they have an ability to already know how to communicate with this uninsured population, and they will be going to door-to-door in the South. So for me, that covered the Southern aspect.
This is Lynn Atkins for the record. What is the dollar amount that is being proposed of the $6 million being paid to Access to Healthcare Network?
I'm sorry, Ms. Atkins, I don't have that number off the top of my head on a percentage basis, how much of the contract total would go to them. Again, the contract will be done on a work order basis. So we're not saying right now the entire $6 million, how it will be spent. The proposal that was given to the committee was chosen overall as, this is the best idea, this is how we like to see this, and now we need to get together with this company and we need to sit down and we need to really figure out all of those details, and that will be put into a work order basis. So we will be able to control the dollar figure for each part of this contract, each phase, like we talked about, education or call to action. If the door-to-door project is chosen, we'll be able to talk about how much exactly funding would go to that. This will be a very controlled process.
So I guess other than Access to Healthcare, how much experience does KPS3 have in the Southern Nevada media market?
And again, Dr. Klein, I can provide you after the meeting with some of the examples of their campaigns that they've had there. I don't have that information at my fingertips.
Is it possible to table this to have some of these questions answered and get a little bit more detail, or is there? I just think at least I'm kind of not comfortable with the information that's being provided at this time, but I'm just one.
Well, I'm not even.
Me three.
It's three of us.
All right, we have a Board of Examiners meeting that we're scheduled to, at least Mr. Hager's scheduled to go to January 8th.
We want to be supportive, I think, and I think, and I mean, and I hate north-south rivalry kind of stuff, and that's not what this is about. I think that's silly. But I mean, you have the bulk of the population here in the South. You have a company that is based in Reno, and when we asked the question, what experience does it have in the Southern Nevada media market, we're told that can't be answered right now. So it's sort of hard to make an informed decision.
Dr. Klein, I think that Shauna's going to go back to the office and get the proposal and bring it back. So let's table it for a little bit and move on to the next agenda items, and she might be able to discuss with accuracy your questions and be able to provide some answers.
Okay, we're happy to wait. We're patient folks.
All right, let's put a hold on concluding item number 6 and move on to agenda item number 7, which is possible action regarding the semi-annual fiscal and operational report to the governor and the legislature.
For the record, John Hager, pursuant to NRS 695I 370, subsection 1B, We are required to provide every June 30th and December 31st a fiscal and operations report to the governor and the legislature. The letter that you see as attachment A and then the report is in attachment B. I'd like to go over just the first 2 pages of the report. The format of the report is very similar to the one that the board approved in June. The first couple pages are a little bit different, and they're actually the same for both this report and the next agenda item. But I wanted to point a couple things out. The Silver State Health Insurance Exchange provides numerous benefits to the state of Nevada and its citizens. It's a system designed by Nevadans for Nevadans. Setting up a state-based exchange allows our citizens to have direct input into the creation of the exchange. While there are thousands of pages of regulations that must be followed, the rules allow flexibility in key areas. Those states that cede operations to the federal government must live with a product created thousands of miles away. Additionally, our exchange will be staffed by Nevadans, from state staff in Carson City working hard to implement the policies provided by our board, to programmers working in Reno to translate the policies into a usable web portal, and to a 50-plus call center operation in Las Vegas. We are trying to be business friendly. Because your fellow Nevadans are providing input to this process, we are creating policies that work for Nevada small businesses. Policies include consumer-friendly design of the shop exchange that limits adverse selection, which is a major cause of premium increases, choosing a free market facilitator approach that maximizes insurer competition on the exchange, allowing brokers and agents to sell products on the exchange. We don't know whether the federal exchange will allow our 10,000-plus broker community to enroll individuals on the federal exchange. In Nevada, they can. Low-cost operations that will save Nevadans on the exchange more than $3.2 million per year when compared to the fees published by the federally facilitated exchange. We can maintain regulatory control over Nevada's insurance market. There are hundreds of decisions that must be made as we transition into ACA-era coverage. Your insurance regulators of the Division of Insurance know the Nevada market better than anyone else in the country. They have been working hard to shape policies that maintain the integrity of the market, which keeps premiums as low as possible. Additionally, the Division of Insurance will be able to ensure that Nevada's navigators and enrollment assisters are properly trained and certified to ensure proper consumer protections. And then ensuring that Nevada's voice is heard. As your state officials work to implement the requirements of the ACA and they pour through thousands of pages of federal regulations, they periodically come across portions of the regulations that could be detrimental to Nevada's market. Your state officials are in constant communication with their counterparts at the federal level to help them shape regulations and ensure Nevada's voice is heard. In fact, Nevada was the first state to raise the alarm regarding a federal misinterpretation of the law that could have cost Silver State Health Insurance Exchange enrollees approximately $15 million in 2014. So we've had a lot of assistance from the various agencies, as we stated in the past, from the Department of Health and Human Services, Medicaid, Welfare, GovShaw Health Division, the Department of Business and Industry, Division of Insurance, the Governor's Office, the Attorney General's Office, the Public Employee Benefits Program, Department of Administration, Hearings Division, Budget Office, Purchasing Division, and Information IT, Enterprise IT Solutions. We've had a lot of help from all across the state, and it's really helped us provide a product that I think will be in the best interest of Nevadans. With that, I'll be happy to take any questions.
Do any of the board members have questions for Mr. Hager? All right. We do need to take action on this?
Yes.
Okay. So do any of the board members would like to make a motion to accept this report so that we can sign it and send it to the governor and on to the legislature?
I would so move, Madam Chair.
Marie Kerr, second.
All right. Any further discussion? All those in favor of the motion?
Aye.
All right, motion passes. Thank you very much. Next item on the agenda is agenda number 8, possible action on our report to the public summarizing the activities of the board.
For the record, John Hager. Similar to the previous report, we are required by statute, NRS 695I370, subsection 1C, to provide an annual report regarding the activities of the board and the contributions of the exchange to the health of residents in Nevada during the previous year. as you can imagine, other than providing education, we haven't been able to do a whole lot yet because we're still implementing. So it's a rather slim report. The first 2 pages are basically the same as the previous report, and then we go into a little bit about some of the policy decisions that we've done and the meetings that we've had, the stakeholder input. But obviously we have not had a whole lot of input to the health of Nevadans yet. Hopefully we will be able to provide a very detailed report at the end of 2014, but I'd imagine also the report at the end of 2013 will be very similar to this, all about implementation and not a whole lot about effect yet.
Okay. Do we have any questions or comments about that report? If not, do we have a motion to accept? No one.
So moved, Madam Chair. Marie Kerr, motion to accept.
Thank you. All right, we have a motion and second on the floor. Any further comment? All in favor of the motion?
Aye.
Aye.
Okay, thank you very much. Agenda item number 9. Possible action regarding the premium payment methods included but not limited to cash and credit cards. And I think, Mr. Hager, are you doing this or is CJ going to?
I'll start off with this, Madam Chair. So we have been, as you can imagine, working on some of these things right up to the last minute. We received some of this data, I believe, yesterday. May have been, actually, I'm sorry, the day before, but relatively recently. So we met with the Treasurer's Office regarding the ability to accept credit cards and the statutes around credit cards, the potential fees. And what we have determined is that generally the contracts with MasterCard and Visa are approximately 1.6, 1.7% of cost. So in the case of a $300 premium, you can expect about a $4.50 charge, $4.50, $5 charge. When we ran the numbers looking at how families are put together and assuming that 25% of the premium is covered by the APTC, assuming that there are 25% of individuals use credit cards, we calculated a $5 per transaction convenience fee if that's the direction the board wanted to take. So we basically have 2 different options. We can either charge a convenience fee to incentivize individuals to use a cheaper payment, such as a automatic bank transfer or something like that. Or you can absorb the fees in the operational budget of the exchange. The difficulty with that is you're charging 1.5% on total premium, not just on the exchange fees. So if everybody were to use their credit card, it would effectively double or almost double our rate that we're charging to the carriers. Assuming that 20% utilize the credit card payment, or 25%, then you would see an increase of about 25% to our fees, because you have to charge that to the entire premium, not just to the amount charged by the exchange. So basically 2 different options there. One, to charge a convenience fee, and based on the contracts with Visa and MasterCard, it has to be a flat fee. We cannot make money off of it, so we'd have to underestimate the amount by a slight amount and then absorb the rest of that piece, extra pennies per member per month, in our operating budget. Or again, you can charge the full amount, which would likely be a couple of dollars per member per month, based on the estimates that we have. It's difficult to say, of course, without any historical data on the exchange to be able to say specifically what we would expect it to be. But those are the 2 options. Additionally, we have reached out to organizations for cash transfers or that accept cash, and Mr. Bowden has been heading that exercise up. I'd like him to speak on the potential to accept cash.
For the record, CJ Bowden. We understand that there is going to be a population at the exchange that needs to use cash methods of payment, and we've researched 2 different types of methods that they can use for cash payment. The first, staff went out and looked at how people pay their current power and gas bills, utility bills at different grocery stores and convenience marts around the areas. And through contacting those stores, it has become clear to the exchange that they contract with 2 to 3 different groups. Number 1 would be Western Union, and the second would be MoneyGram, and then a distant third was Check Free. And the costs associated with the cash collection on those parts range from $2 per transaction to $5.99 per transaction. MoneyGram was at the $2 level, and Western Union was at the $6 level. Western Union says they're working very hard on a ACA compliant program, and they will most likely lower the costs on ACA transactions to pay premiums with cash to around the $3 mark, but they don't have anything set yet. That fee would fall outside of the premium and would not be considered under premium tax or a fee. The second solution to paying cash would be to convert the cash payment into a money order and mail it into the exchange, and it would cost a person approximately $1.15 to do that, 50 cents for the money order, 44 cents for postage, and assuming a 25-cent envelope. So if we're at that point, we have 2 different sections. They could walk in if we held a contract with Western Union or MoneyGram and pay at multiple locations, approximately 200 MoneyGram locations in southern Nevada and over 100 in northern Nevada, and many more Western Union locations. And then the other solution would be there is no cost to the exchange on the MoneyGram or Western Union sides. It's just the cost to the consumer. The other solution would be mailing that in, and it would cost the consumer about $1.15. So those are the cash collection options that we've looked at so far.
Does Ron Klein, does Xerox contemplate having an office that's open to the public, and for questions? And if so, could we alter the contract, amend the contract so they could have a cash collection area, sort of like paying your electric bill or cable bill kind of thing?
For the record, John Hager, first let the record reflect that Dr. Ford has arrived. Second, the proposal that Xerox provided included some brick and mortar locations in the RFP. They were options that we did not include in our contract because of the additional cost. We had anticipated that an individual would be able to go to a navigator or broker to enroll. Obviously, we weren't thinking at the time about collecting cash specifically, which is one of the reasons why we rejected those options. The cost of those brick and mortar locations was several $100,000, maybe up to $500,000 per year. I can't recall exactly. It was back in May when we negotiated that contract, but I think that's about what it would cost. Just rough ballpark. Again, we'd have to go back to that RFP, but probably about $500,000 a year to open up brick and mortar locations to accept cash. I think that included three or four locations. I think 4 locations. One in Reno, one in Vegas, one in Las Vegas, one in Carson City, and one in Ely, I think, or Elko. But just those 4 locations. Unfortunately, that would also mean then that there are areas that would have a more difficult time getting to those locations to pay cash, which is why we've been looking at the Western Union or the other option that Mr. Bowden described.
Possible, I'm just sort of, and I don't know if this might be a silly statement, but I just popped into my head. Is it possible to contract with a cable company, electric utility, phone company that already has that set up to do that? And I have no idea if what I'm saying makes any sense, but I just
currently, I researched those different options, and currently both Southwest Gas, Charter, and I think it's Embark down here, they all contract with Western Union and MoneyGram themselves and use that service at bill pay at grocery stores.
So CenturyLink is not. CenturyLink, Southwest, you can't go to their offices and pay your bills there in cash?
You can go to their offices, yes.
So the question I had is, would it be possible to contract with Southwest Gas or CenturyLink and have them provide a service for us to allow people to pay their premiums, take custody, if you whatever, take control of the money, and then just work through them, since they already have the bricks and mortar location set up.
I have not researched that option
And I
yet.
have no idea if that makes any sense or not. But.
Some of the backlash that we got with the different grocery stores was they were concerned taking insurance premium payments even through their Western Union and MoneyGram locations. Some of the individual staff was concerned at the fact that this was an insurance premium that they were taking in, and if their staff keyed it wrong, the transaction would not go through. It would be held up, and they were worried about maybe cancellation of coverage issues. So that's some of the conversation that we've had from individual store owners, not from MoneyGram nor Western Union, but individual stores and staff.
CJ, I don't know how many of the kiosks that DMV has, but have you looked at the opportunity of working with them? And it may be that the kiosk is credit card only, I don't know.
For the record, John Hager, so we have had some discussions with DMV regarding using their kiosks. They have kiosks all over Nevada, including at their offices. The kiosks at their offices accept cash. The kiosks that they might have in grocery stores, et cetera, do not accept cash because of the security requirements of getting the armored truck to the various locations. But they do accept cash at their offices. We've had some very initial discussions about doing that. There would be a similar fee, convenience fee, for accepting cash at those locations in the $1 to $2 range. So that is also an option.
I guess the concern I have about some of these add-on fees, when you get down into those lower subsidy amounts, I mean, where the subsidy is really picking up most of the premium, the fee could almost equal what their part of the premium is per month.
$18 premium?
Is it like $10 a month?
We'll make it to that.
It'd be flat fee, yeah.
Mr. Hager's going to look up at, we're kind of at the starting point, what we anticipate the premium will be for those like at the 140% of poverty level.
So for an individual, I'll use 133%. There's a 5% margin, but 133% of the federal poverty level currently for an individual is about $15,000. For a family of four, it's about $31,000 per year. That's annual income. Their premium costs for that individual would be $37 per month approximately. And the premium for the family of four at that income level would be approximately $77. So in the case of the credit card convenience fee, it would be $5. And that convenience fee can be changed. It doesn't have to be $5. It can't be more because that's about the threshold where we start making money off of it, and we're not allowed to make money off of it, which, the idea is not to make money, but simply to cover the cost of it. Then if you look at the union, Mr. Bowden's options, several dollars, MoneyGram and Western Union, several dollars there. The kiosks, $1 to $2. And then the other side of that is if we set up brick and mortar locations, there's a cost that's distributed to all participants, whether they pay by credit card, automatic bank transfer through the internet. All participants would absorb that cost. One of the things that we've learned is there's no free lunch in this. That's a key takeaway. So we either need to decide that we will absorb the costs of accepting funds that way and distribute that cost among all participants, that we will charge a convenience fee to incentivize individuals to use methods that are less expensive, or that we don't accept them in certain manners. And that those are basically the three options.
Marie Kerr, Okay, so this may be a little different, but I've been looking at this. I have had this email on my email server for a while. It's regarding Intuit payment network, and I haven't checked it, and I've been thinking about it for my business, and they charge 50 cents a transaction. And so, 50 cents versus $3 just sounds a lot better. And I don't know if they do it for large. I don't know how they, I haven't looked at it at all, but maybe staff can take a look at something like it. It looks like it's some sort of e-check thing versus using the Visa and the MasterCard payment network, which could be a little cheaper. And, again, 50 cents sure sounds a lot better than $3 or $5.
So there are two contracts with the Treasurer's Office. One of the contracts, I think one's an e-payment and one's a credit card contract, or it's something like that. They're sort of layered on top of each other. To accept the credit cards, you also have to have the e-payment section, and so not only is there the 1.6%, but there's a 20-cent per transaction fee. If you don't do it by credit card, if you do it simply by bank transfer, by e-check, it's 20 cents. So we have looked at that through the Treasurer's Office. Because of the way we are outsourcing this with Xerox and the reconciliation and the money transfers and a lot of the statutes that go into this, not just in our statute, but all of the Treasurer's statutes and the money collection statutes, it becomes complicated. So it might be done at the Xerox level specifically. We have to work with Xerox to determine that. But our guess is that we'd be able to work out some kind of a fee, like an understanding to get around that 20 cent or 50 cent transaction fee. Now, Xerox has indicated that they will only charge for the merchant fees. It's again, we're not sure exactly where that threshold is, but we're pretty confident we can go forward and accept checks for little to no cost, that we should absorb the electronic check, the electronic bank transfer in our budget. The issue becomes accepting cash and credit cards. It costs a lot more money to accept cash and credit cards. And so, again, we can do it electronically, do it on the web, and there will be no additional cost to the individual unless you use your credit card. And so, again, the options, charge a convenience fee, absorb the cost in our budget, don't accept it. The other option, again, is to build those brick and mortar locations and absorb the cost among all participants as well.
So if we absorb the cost for the e-check of 20 cents or so, and then charge a convenience fee if you use your Visa or your MasterCard or Amex or whatever, and just covering electronic payments, it certainly would push me towards using e-checks versus using a credit card. And so it seems that, and I'm just an average consumer, I think, in terms of do I pay something or do I pay nothing. And in terms of cash, that's still going to be problematic. But I think it's going to exist regardless of whether it's your insurance payment, it's your Southwest gas payment. That's still a problem for people who use cash. I think my opinion is the money orders just sounds like the best option.
I think the other thing that I'm concerned about is when you get down into those lower poverty levels, you're going to see people that don't have credit cards and they're not going to have checking accounts. And their only way of making payment, if they're part of the exchange, is through cash. Have we thought about putting out an RFP to see if there's an entity or entities out that have a statewide presence that might accept cash transactions? For, like you're saying, Walmart or Bank of America or someone where they've got a presence in every location.
So the Western Union and MoneyGram organizations have locations in just about, they're located all over Nevada, and that seems to be the groups that can actually accept cash. When we call the Walmarts and the grocery stores, they refer us to those organizations, or they don't want to do it at all. So we haven't sent out an RFP or an RFI. We could do that. The question will still remain, do we absorb that fee or do we charge the convenience fee? The other thing I'd like to indicate, the CHIP program, the Nevada Checker program for kids does not accept cash currently. Now, if we were to do this, then it would be then if we accepted cash, it would be part of that process, and they would accept cash. But they currently do not accept cash. They only accept check, money order.
Cash, money order.
Only money order. Money. They only accept money order and checks. They do not accept cash or credit cards.
I guess what is the pleasure of the board then?
Do we have?
We can't hear you. Can you?
Are you hearing us okay now?
We can hear you now.
Okay, great. Ron Klein, just a question. So what I was saying was, if somebody has a $300 premium and there's a $280 subsidy by the federal government, then they're paying $20, not $300, is my understanding. So doesn't that change the 1% merchant's fee from $3 or $4 to whatever, 18 cents, if I'm doing my math right, 20 cents on an $18 premium?
It would, yes, it would lower the amount of the convenience fee. So before we decided how much that convenience fee would be, we would have to do some more research. We'd have to get a distribution, an expected distribution of our enrollees on who would, number one, who would pay with credit card and their income levels, to figure out what their amount would be. As I said, we only assumed in this discussion that 25% of premium would be covered by the APTC. Obviously, it could be a lot more than that. We wanted to be more conservative and provide the board with a higher dollar amount, so it could certainly be lower than that. But yeah, so a $100 premium, you would for a $100 premium, if everybody that used credit cards had a $100 premium, then we could charge about $1.50, $1.70 to break even. The problem is that based on, it was a contract with either Visa or MasterCard, I can't remember which, they don't allow a percent. You have to have the same dollar amount convenience fee for all participants in a program. So you'd have to figure out the average cost paid by all enrollees. So certainly it would likely be less than $5. That would be on the high side. But I would expect it to be, on the other hand, certainly higher than the $1.50. You're probably looking at a $2.50, $3 range.
Do we need to make a decision on this particular item today? Do we have time to maybe mull it over until the next meeting and come up with some maybe a proposed recommendation that would be the best way to go through it? I guess the easy question is, rather than the long-winded version, is do we need to make a decision right now?
So the answer is yes and no, like all of our decisions. So we're going through the budget process, and obviously we're supposed to have our agency request budget submitted a while ago. But we've been making changes, and I think that the budget office and LCB Fiscal has understood that this is an implementation, that there's a lot of unknowns, and we're doing this as quickly as we can in the most thoughtful manner that we can. The latest deadline that we have received from the budget office is this weekend. However, just because we don't have this piece of information doesn't mean we can't consider it in January and contact our LCB Fiscal staff and make a change at that point. So we are getting to the point where we are past being able to do anything for the governor's recommended budget. We can still go forward with this. Hopefully, the LCB will continue to support our changes. So the major issue, though, is whether we absorb it or charge a fee. If we absorb it, then our budget, our per member per month fees go up. And actually, I have to back up. We have indicated that we're going to set rates in January. If we absorb it, we have to have that before we post those rates 15 days prior, which is in the next couple of weeks. Now, if the decision is to either charge a convenience fee, which would not cost us any money or an insignificant amount of money, or to not accept a certain methodology of payment, that decision can be made later. So the issue is if the board wants to absorb those types of costs in our budget, then we need to consider that basically today. The only thing that we can absorb is the credit card fee. We cannot absorb the cash collection fee because that is charged at the point of service, at the kiosk or at the grocery store, wherever they're accepting the cash. So it's complicated, like most of our issues.
So we could absorb, there are different, during the different methods of payment, we could absorb an e-check fee, which would be low, and we could charge a convenience fee for credit cards, and then for cash, we just really, they have to send in a money order. I think that would be the best way to do it. And in terms of just listening to the back and forth, as I'm sitting here, that sounds like the best way to do it if we had to make a decision today.
Okay, should I'd like to may I make a motion if I can?
Certainly.
Madam Chair? All right, it's Ron Klein. I would move that the Health Insurance Exchange charges a convenience fee and does not absorb the cost of credit card transactions.
All right, do you want to deal with the cash later and just move past this one item?
And well, no, I will let me broaden that then. I mean, I think that we should not absorb any fees for cash or credit card transactions. That those should be the client, customer, whatever term you want to use.
Okay. All right, just a moment. Mr. Hager wants to say something.
So just to be clear, there will likely be a small portion of the credit card fee that we would absorb because of the statute that says that we can't make a profit on it. We have to make sure that we absorb a small piece of it. So
understood.
So if I could be so bold to propose an amendment to your
Call
motion,
them a friendly amendment.
Yes, to simply charge a convenience fee for the acceptance of to charge a convenience fee for the use of credit cards or the acceptance of cash. And we'll leave it at that.
Accept your friendly amendment. Sounds fantastic.
All right, do we have a board member that would like to second that motion?
Marie Kerr, second.
All right, thank you. Any?
I have a question.
Yes.
This is Leslie Johnstone. I just wanted to clarify that Xerox can administer all of these methods without any additional cost beyond what we've already committed to.
We still have to work out the details with Xerox on how this is going to go forward. We think that I can't commit to anything with Xerox, but we think for the most part going forward we'll be able to administer what we need to under the current proposal. But again, I can't commit completely.
When will you know?
Soon?
Well, that's a good federal term lately.
Yeah. we can have a committed answer by the January board meeting.
Okay. All right, thank you very much. All right, we have a motion and second on the floor. Any other questions or comments? All right, I'll call for the vote. All those in favor?
Aye.
Aye.
Any opposed? Okay, the motion passes. Thank you. Do we
Madam
want to?
Chair, I think the record needs to reflect Ms. Lewis left, I think about 20 minutes ago, and she believes she'll be back around 2:15, so she was not present for that vote.
All right, thank you. I appreciate that.
I'm doing a terrible job here, John. You shouldn't have given me this task.
You know what? Maybe we'll give it over to the vice chair and let her do it.
I think you should. She's doing a much better job. Yeah.
Why don't we take a 5-minute break and let me find out from Shauna if she's about ready to go back to that agenda item. All right, let's go back on the record. If we can, please. And Shauna, we're going to go back to agenda item number six. And I think that we've asked the principal of the company to join us by telephone. They may be able to help us with some of the questions that we've got. And then
For those that are on the phone, if you could please put your phones on mute unless you're asked to speak or during public comment when you're ready to speak as well.
And also, please do not put your phone on hold. Those are the things that cause issues for us here. So, all right, Shauna.
Madam Chair?
Yes.
Madam Chair, it's Lynette Kinsdown in Las Vegas. Ms. Lewis was hoping that she could be here for the continuing discussion of the marketing plan, and I believe she's going to be back around 2:15. I don't know if it's possible to hold this item until she returns.
You know, we have Stephanie Cruz on the line, who is principal of the company that we're talking about, and I don't know what her agenda is like. Stephanie, are you there?
Yes, I'm here.
If we ask you to come back on the line, say at 2:30, would you be available?
Yes, I'll delay an appointment that I have at 3.
Okay, I think that'll give us time in case LaVon is a little bit late. She's expecting to be back about 2:15, but I'd like to give her a little bit of extra time just because of traffic or things. Okay?
Thank you.
Thank you. All right, then. I'm losing track of where we are on the agenda right now.
10.
And we're at
10.
Item 10. Okay. I have had, during the break, a couple of persons asked to make public comment as we start going through the advisory committee recommendations. Might I get a show of hands from North Las Vegas, if anyone there wants to make public comment on any of the advisory recommendations?
Seen none.
Okay, thank you. How about here in Carson City? Not one. Anyone on the telephone? Doesn't sound like it. Okay, and I believe this is agenda item number, or recommendation number 7.
Consumer assistance, probably.
Under consumer assistance. So when we get to that item, then I will open it up for public comment. So, right, so finance and sustainability, the committee work is complete, and then plan certification has 1, 2, 3, 4, 5 items that are up for recommendation. So I'm going to ask you to help us get started on this while I try and find it on here.
Okay.
Okay.
For the record, John Hager. So there are 5 items under recommendation 6 regarding plan certification, and then recommendation number 7 and 8 is also under that committee's work. So we had a brief outline at the November board meeting about the plan certification process regarding a formal review in the future, regarding allowing any qualified health plan to be offered on the exchange with the limitation of 5 qualified health plans per tier, per insurer. And then we discussed allowing the Division of Insurance to certify and recertify plans, and the decision or the recommendation of the committee to decertify, to retain the ability to decertify qualified health plans that cease to meet the requirements of the exchange, the Division of Insurance, or the Affordable Care Act and its regulations by majority of the vote of the board, and then to set up a process for decertification. I'm not sure how in depth you would like us to go into that, since we talked about it in November. Although I think Commissioner Kipper has some input for the for item D. I'm sorry, for items E.
E, okay. And I recall, too, we didn't have time to cover all of these issues at our last board meeting, so we tabled it. And I believe that there was someone from your office that wanted to make a correction on something, and neither John or I can remember what it was. So maybe as we go through these items, you'll you'll flag it for us if it's something that you see.
Yeah, Madam Chair, for the record, Scott Kipper. I will attempt to do that, although I do recall that our staff that was in attendance was pretty clear with what they had to say around the issues of certification, recertification, and decertification. As we walk through this, and I would ask the director to kind of walk me through a little bit, because I do have some comments I'd like to share with the board.
So recommendation number 6 starts on page 5 of the pending board approval. The advisory committee recommendations pending board approval. It's attachment A, page 5. The first item is that all plan certification policies will be formally reviewed in the spring of 2015. We went into, I think, a fairly in-depth discussion about when is the appropriate time to review all the policies, and that staff is committed to a continual review of the policies as things come up. We will flag them for the board's attention or discuss them with the Division of Insurance or both, and look at them individually. We discussed that for something like consumer assistance and the ability to enroll in plans, if perhaps standardization of plans, we should be able to get some data back after the first open enrollment. So it is probably appropriate to do a review of the enrollment process starting immediately after open enrollment, so that we have data and we can affect change in the next open enrollment. For decisions such as going from a free market facilitator model to an active purchaser model, we need to understand where rates are going to fall out. The difficulty that we have is that the carriers are going to set rates for 2014 based on hundreds of unknowns. The Affordable Care Act is going to shake the market up considerably. We don't know what's going to happen. We don't know how the carriers are going to rate each piece of the various unknowns and create premiums in 2014. Once we are in 2014 and they start receiving claims and start understanding what the financial impact is in 2014 going into 2015, they really won't have an idea of 2014 until truly till about 3 months after the end of that plan year. And even then, you're probably going to see some changes in patterns that will take a couple years to shake out, to even out. And so really you're not going to have a good understanding of what the market has done to claims and then therefore to rates probably until 2016. The difficulty, though, is if you review something in 2016 and we make changes to our policies in 2016, you really can't make those effective until plan year for 2018. So the recommendation of the committee was to formally review all plan certification policies in the spring of 2015. I don't know if you want to continue or if you'd like to stop there and discuss that item.
No, and I think this was a great concern to Dr. Klein, who serves on that committee with me, that we make sure that at least on an informal basis that staff is keeping us advised of what's going on, so that if we do need to make any policy changes, we keep ahead of it instead of behind it.
Yes.
And does that accurately state
Yes,
what
thank you.
your concern was?
Yeah, exactly. And I mean, I think with all the appropriate caveats that John has specified, I mean, we have a responsibility to see what's happening as the exchange moves forward. So it's just with all the limitations that we're aware of, we still need to look at it. So yes, thank you.
All right. What I'd like to do is just move.
If I could, a couple of things that I feel compelled to talk about a little bit. I don't really believe that the insurance industry will not be able to nimbly react to claims in 2014 until 2016. I think the actuarial sciences have developed enough that they can reasonably anticipate, even today, if they have a blueprint or a set of events that they are to insure against, a set of benefits that they are to pay, that they should be able to, with some reasonable certainty, come pretty close to what the cost of that is. I think the untold or unknown right now is utilization.
and who's going to utilize this. I would suggest that the Division of Insurance, through working with the industry, would be able to report back to the board much quicker and be able to provide the board with an update as far as how things are going, especially in terms of the issues around certification, much faster, I think, than what Mr. Hager just kind of laid out. I think we can do this collectively between ourselves and our regulated entities much quicker than that.
All right, so are you suggesting a formal review take place in 2014 then?
I would suggest that in our everyday monitoring of the marketplace, that we would be able to provide quarterly or semi-annual updates as discussions about trends, about benefit utilization, about pricing and premium levels. I think that we would be able to be much more reactive than the time frames of reporting in 2016 on what has taken place in 2014, for example.
Well, and that could be part of our informal process then on keeping the exchange, advised of what's happening out in that free marketplace.
And I think I would be well within the authority that we have in making an unofficial or even as directed by the board a request to provide an official update on a semi-annual basis in perhaps January and July time frames as to what's taking place in the market. I think that would be a better benefit, better use of our time to provide those types of updates.
I would ask Mr. Hager your thoughts on administering it with semi-annual updates from DOI.
Sounds great.
I would, for the record, Shauna DeRoos, if we could talk about the time frame a little bit, that might be very useful information to include in our semi-annual governor's report. And so as an alternate to January and July, if we could do March and October or something like that, so we could get that information, have time to include it in that report, and bring it to the board for their approval before we turn it into the governor.
Sure.
If I might just ask the Commissioner one question. You said quarterly, or is that too frequent?
I think quarterly might be too frequent. I think certainly semi-annual would be ideal.
Okay. Dr. Klein?
Yeah, I was just going to say that's fine with us. I mean, I think the only point of the recommendation was that we don't put our heads in the sand for 2 years, but that we continually monitor what's going on. So, biannual is fine.
Why don't we do this? If it's all right, we'll just say biannual, and let the exchange and the Division of Insurance pick the appropriate dates. Okay.
Madam Chair, that's semi-annual.
Semi-annual, yes. I'm sorry. Thank you.
Just want to get that straight.
All right. Do we have a motion to that effect? Dr. Klein, you want to help me with that one?
I move that we accept Mr. Kipper's recommendations that the Division of Insurance makes a report to the Health Insurance Exchange on a semi-annual basis.
Seconded. Lynn Atkins.
Thank you. Any further discussion? All those in favor?
Aye.
Aye.
With a start date of April of 2014. Is that with April and October, or as determined by the executive director, whatever you guys want?
We were going to let staff decide what worked best between the two departments.
Sounds perfect.
Thank you. All right, we've already taken the vote on this, and the motion passes. So, next item on the agenda is, notwithstanding any requirement or limit to the contrary, any health plan that meets the requirements of the exchange, the Division of Insurance and the Affordable Care Act and its regulations will be certified as a qualified health plan to be offered on the exchange.
For the record, John Hager, 45 CFR Section 155.1000 requires the exchange to only offer health plans that have, in effect, a certification issued or recognized as plans deemed certified for participation in an exchange as a QHP. We have in place currently a memorandum of understanding that allows the Division of Insurance or provides that authority to the Division of Insurance to certify plans. While we have indicated that the MOU is a living document that will be changed, it's a good guide to start forward. And then confirming that decision in the MOU was this recommendation from the committee. The committee recommended and the board approved the free market facilitator principle back in April of 2012. The free market facilitator model provides a general structure capable of facilitating market competition, establishes basic rules for buyers and sellers, and serves as a source of reliable, impartial, transparent information about the available plans. It's expected that the free market facilitator model will ensure the maximum participation by insurers and the widest choice for consumers. Therefore, it follows that any carrier that wishes to obtain a certification for a plan as a QHP may do so as long as they meet the requirements of the exchange, the DOI, and the ACA.
Do we have any comments from board members on this?
Yes, Ron Klein. I'm sorry.
Go ahead, Dr. Klein.
Okay, I'm getting my letters mixed up here. How does B that it gives the power to certify a health plan to the Division of Insurance work with, is it E that retains the right of the health insurance exchange to decertify? Is that E? I mean those two conflict, and I just want to know how that works.
And actually, I think that Commissioner Kipper is going to speak to us on the conflict on it. So,
can I start though?
Okay.
I misspoke when I started going into the MOU. That actually goes into item C. So C, D, and E are the issue that Dr. Klein just spoke about. So item B is just a confirmation that any plan that wishes to be a QHP may do so as long as they meet the QHP requirements. So I don't know if you want to wait on that question for just a second and handle the free market facilitator question in B, or if you want to go ahead and go forward with that. I confused everybody with my opening statement.
Okay. So, Dr. Klein, your question really relates to items C, D, and E.
Well, it seems to me like B and E are contradictory, because B says, if I understand correctly, B says the Division of Insurance can certify QHPs, and E says that the Health Insurance Exchange retains the right to decertify. So I just don't know how those two legally would mesh together or not mesh together.
Yeah, why don't we go ahead, Commissioner Kipper, and let's discuss item E then. I think that'll tie it all together.
I think so. For the record, Scott Kipper. In looking at this and in having internal discussions with our staff, it makes sense for us to bring to the board a discussion on certifying, recertifying, and decertifying. We have obviously the expertise in our staff in compliance. We review plan for contracts for compliance all the time. We also review plans for financial the financial wherewithal in order to continue to do business. We look at and investigate all the complaints that are lodged against insurers, including health insurers. And so I guess the point I'm trying to make is
we already have the expertise and the staffing and the experience to do the certification and the recertification. I would just make a point that it makes sense for us to apply all of those same standards in the impartial way that we do now on decertifying. And we have also the standards in place and the penalties in place if an insurer doesn't live up to their contractual obligations, doesn't meet their financial obligations, that we have the ability, the authority, and in fact do this every day, is take action against those carriers that aren't complying with their requirements. So I would just say that we have the staff, we do it now, that it makes sense for us to go ahead and also decertify plans when they have not met their obligations.
Well, and the other comment that I would make on this as well is that the opposite of recertification, if you decide not to recertify someone, is a decertification, which is what you're doing.
Exactly.
So, and I don't think the intent of the advisory committee was to duplicate services or make a process more difficult. I know at one time, and Dr. Klein, please jump in on this, but I think there was a concern that there was a statutory requirement that we might have to do that, and I don't remember what that discussion was.
No, with respect to Mr. Kipper, I can envision a time, and this sort of gets back to that passive purchaser versus active purchaser model that you choose to have. I can envision a time when the health insurance exchange is so successful that we may choose to raise the standards for playing in our sandbox beyond what the Division of Insurance might have. And so I think it's important that the health insurance exchange, if you will, control its own playbox, its own sandbox. That we can go to an insurance company and say, and obviously not a single individual, but a majority of the board that says, you're not really behaving the way we'd like you to behave in terms of taking care of your covered lives, and if you're going to play here, you need to improve. And I recognize that Mr. Kipper's division does the same thing, and I would just respectfully say, as a physician in this community, there's a lot of bad behavior that goes unpunished. And a lot of very good insurance companies, but a lot of behavior that's unacceptable. And I'd like to see the health insurance exchange retain the ability to say to companies that are going to work through our exchange, that have some kind of regulation over their behavior if they're not behaving well. So I think there's an important difference here. I think that we should retain that the Division of Insurance has, and I don't mean this not disrespectfully, but minimum standards to function to that. And I think there may come a time when the health insurance exchange wants to raise the bar a little bit within itself.
This is Marie Kerr. So I'm looking at three different areas for decertification. One is ceases to meet requirements of exchange. 2 is ceases to meet requirements of DOI. And 3 ceases to meet requirements of ACA. And our sandbox is obviously the first one and the third one. And I can see your point. I mean, if we have some sort of conflict where DOI says something and we say something different, we're going to have a conflict, and it just, and insurance and people's lives hang in the balance, and that's not good. Can we still meet the standards? Have we had a legal review to determine whether or not we can still meet the standards of Section 155.1000 sub C if we said something like, if we, 1, cease to meet the requirements of the exchange, which is our sandbox, 2, which is found by DOI to cease to meet the DOI requirements, and then 3, the same, cease to meet the requirements of the ACA. That way, we're still controlling our sandbox, but we're avoiding this conflict with DOI. Have we done that review to determine whether or not that can be done?
For the record, John Hager, we have not conducted a legal analysis of that. However, the regulations make it very clear that certification, recertification, and decertification are the function of an exchange. What we have done with items C and D here is to say that the Division of Insurance is in the best position to do that business function for the exchange, and they will work as our agents to do the certification and recertification. And so the question then is, would we want the Division of Insurance to continue would we want to use the Division of Insurance in the same manner as our agent for certification, recertification, and decertification?
Could we, this is Ron Klein, I apologize, could we sort of meld the language a little bit and say sort of, if you will, like the advise and consent function of the Senate under the Constitution here? Can we say something like the Health Insurance Exchange retains the right to certify and decertify plans, with the help with the advice of the Division of Insurance? Does that something like that work?
Dr. Klein, again, for the record, Scott Kippert, I'm not going to address that for the moment. But if I could, first of all, you mentioned the issues around bad behavior. We have a significant staffing level both in Las Vegas and in Carson City that respond to complaints, either consumer complaints or provider complaints. And out of those complaints, we gather data, and if there is a consistent pattern of bad behavior, we have a significant number of tools at our discretion to go after those bad actors. So I would suggest that if there is bad behavior going on and we are not informed either from providers or consumers, we need to be. I'm concerned that there would be a concept or thought going on that might surface at the board saying there's a provider or a carrier out there that is providing bad behavior that has not been brought to us, that they are automatically or raked over the coals in a decertification process when they don't have the ability to sit in front of their regulator and explain it. So I'm most concerned that we could get into a situation where there may be either an axe to grind where, and we get this a lot, is there's some misunderstanding by a provider, misunderstanding from a consumer of what is actually in that insurance contract, whereas the insurance company is acting within their rights. And I'm not saying that all happens all the time. Certainly insurance companies do try on occasion to not pay those claims. So I would hate for that type of situation to get to the board level in a decertification process. Also, the MOU, as John pointed out, is not one of those legally binding things, but it does provide the Division of Insurance the oversight as the primary agency for certification, recertification, and decertification, and that is a document that all three agencies signed off on: the Exchange, DHHS, and the Department of Business and Industry. And finally, the last point I want to make is that we are not subjective in what we enforce. We are given laws and direction to create regulations from the legislature on how we are to regulate. So we don't have a subjective authority, very much an objective authority. And to suggest that there is bad behavior going on that we don't look at, it is because we're in all likelihood not aware, have not been made aware of those allegations. So not to carry this on, but I am concerned that the professionalism that we bring to this would not necessarily be taken into account on the decertification process.
Commissioner Kipper, the other thing that I'd like to ask you about is if you had some other entity like the Health Insurance Exchange taking that role on by itself, and they decertified an insurance company in the middle of a policy year, that has a significant effect on people. I mean, that would have a very significant effect on individuals within the exchange.
A huge problem, because that would leave most of those, if not all of those individuals, scrambling to find new coverage and creating new deductible levels, for example, that they would have to meet in midterm would just be one of the issues that these individuals would face.
So the due process would be, there'd be a due process, and it would occur at the beginning or end of a plan year. It doesn't seem too complicated. I mean, and I think in terms of axe to grind, I mean, you'd have to have a majority of your board vote to decertify, so it's not a single individual doing that. Again, I mean, I think the simple answer for me is that, you know, we're appointed by the governor, speaker, and Senate Majority Leader to take responsibility over the health insurance exchange, and part of that by federal law is certification and decertification of plans, regardless of what the MOU says. And I don't feel comfortable ceding that authority. I'm certainly ready to listen to the Division of Insurance in any kind of certification or decertification process, and I would expect to listen to them, but I don't think I would cede the ultimate authority to the Division of Insurance.
Dr. Klein, then I would suggest then we need to go back into a budgetary mode, because we're going to have to staff up for all of that. And I'm not sure that we're staffed to do certification, recertification, and decertification.
I really didn't intend that, and I think what I'm intending is being taken out of context. I'm happy to have the Division of Insurance recommend to us certification, decertification, to sort of be our advisor, if you will, in that role, and let their staff do what their staff does best. I have no problems with that. But ultimately, the decision as to who plays in our sandbox belongs to the board of the Health Insurance Exchange. That would be my view.
This is Leslie Johnstone. I have been coming at this a little bit different angle for, I think, positive reasons, that the Division of Insurance, it seems to me, is the body that ought to say who is a qualified health plan that the exchange could entertain as including in its panel of carriers. But if we did become an active purchaser board, then the board ought to be able to say, for different reasons, don't even have to be a bad apple, for different reasons, we would like to take what we think are the cream of the crop carrier and insurance plans, and not take every plan necessarily that were certified by DOI. So is that a different issue than what we're trying to distinguish here? I mean, it seems like
what you said. No, I mean, I was saying in a positive way, and I agree. And I said in a negative way, and I agree with what you said in a positive way, that there may come a point at which there's not necessarily bad behavior, but there's good behavior, and we want to reward the good behavior. As a parent, we want to reward the good behavior. You know, it's not necessarily punishing the bad behavior.
For the record, John Hager. So just to make sure everybody understands, we're going to make these policy decisions. They are exchange policy decisions. They're not necessarily in reg or statute. They're not in statute. And so they can be changed at any time. So if there is a decision in the future to go to an active purchaser model, we could certainly change this at that point. It might make sense to change all of the discussion about certification of qualified health plans if we go to an active purchaser model. So that might be something to consider.
Madam Chair? I mean, we've already done this a little bit where we wanted to limit the number of plans that any one carrier would, at any one metal level, would have on the exchange. So there may be more than what we set as a limit for this first cycle that would meet the certification requirements of DOI, but we wanted for other reasons to limit the number. So I think we've already done this a little bit.
And Dr. Klein, I guess I'm sympathetic to your concern about the bad apple or someone that behavior problems. Wouldn't it make sense that if those issues come before our board, that we would then turn to the Division of Insurance to do the investigations for us to make sure that it's not somebody trying to take a public forum and berate someone for a reason that's not justifiable, or maybe it is. But I'm not sure.
I would agree, and I would agree with that. Sorry, I would agree with that. I want to be clear because I think the issue is getting a little bit muddied, and I want to make sure it's not muddied. The Division of Insurance has the staff and the expertise to investigate and report to us about issues that we may find that there are problems. But ultimately, after the Division of Insurance reports to us, the authority to make that decision should rest with us. And I want to compliment Ms. Johnstone for saying something in a positive way that I said in a negative way. It may not just simply be bad behavior. It may be that there are certain better companies out there that do an extremely great job, and we want to say, we can't have everybody play in our sandbox, so we're going to pick the top 3 or 5 or 10 or whatever it is because you get the gold seal of approval and you've delivered exemplary care to the people you insure. And I think that would not be a Division of Insurance decision. That would not be a Division of Insurance saying, excluding somebody based on bad behavior. It would be the Health Insurance Exchange Board rewarding somebody or some company based on good behavior. And I think that's a whole different thing. But again, the investigatory authority, I leave with the DOI. They have that expertise, but the decision has to rest with our board.
Let me pose a different situation to you, and just to walk through this just a little bit more, and Commissioner Kipper, if you would jump in on this too. What if the Division of Insurance was going through a recertification process and decided that qualified health plan who was in our sandbox should be decertified or not recertified? And I think these are confidential proceedings during part of it. Would that mean then that the Division of Insurance would have to come to us in order to get the authority to do their normal work?
Well, I don't know. I mean, Mr. Kipper would know this much better than I would, but if the Division of Insurance decertifies a plan in the state of Nevada, I don't think we can certify them within our exchange. I mean, I think they have to be approved by the Division of Insurance to even be as part of our exchange. Is that not correct?
That's correct, and I think that the point that the chair made was, I think, right on, in that we may not recertify based on any number of things, and let's just pick on a high level of a specific complaint or a high number of specific complaints, and I think at that point we would say, not only are you going to be subject to sanctions from the division as we investigate and do a market conduct examination, but we would share once we have findings and once we have had given that company an opportunity through due process, that we would share those findings with the exchange board.
So what if the language said the health insurance exchange retains the right to decertify a plan in consultation with the Division of Insurance? Is that language Does that language work?
Well,
To be part of the exchange. Yeah.
John and I were saying perhaps a better starting point might be that the standards that are created jointly by the board and the Division of Insurance. So it's very clear, and both sides have agreed what those standards are, so that if there is a deviation, it is very clear what the ramifications would be.
For the record, John Hager, Commissioner Kipper, when we talked about we have certain policies, and I believe your office has agreed to ensure that in the certification process, the qualified health plans meet those standards of the exchange. In a future year, if we decide that we need to reward or not necessarily reward, but change the standards to raise the bar, I would assume that you would ensure in the certification process, if you were still doing the certification process at that point, that you would adhere to those standards, since those are the standards that we have come up with.
There we go. For the record, Scott Kipper. I think that makes some sense. We are tasked with making sure the marketplace in its entirety functions as efficiently for Nevadans as possible. And we would like to think that we would have an opportunity to certainly share our viewpoint as to if a standard needs to be raised, what that might do not only to the exchange but also to the entire marketplace. We have had, it's no surprise that we've had a significant shrinkage in the number of carriers that are doing business in our state, down to where 15 years ago we had double digits, almost triple digits choices. Now, the number of choices you can almost count on one hand. And I would say that we would certainly want to make sure that the point of making sure that the marketplace doesn't go to heck in a handbasket because we're raising standards and drive carriers out of the state or out of the exchange because we're raising standards. Just that point needs to be made during those discussions, and we would be certainly making that point.
Dr. Klein, do you have a suggestion on language?
My motion would be that we accept recommendation E. As worded, the exchange may decertify a QHP that ceases to meet the requirements of the exchange, Division of Insurance, or the Affordable Care Act and its regulations by majority vote of the board. The exchange will set up a procedure for decertification, presumably, due process of a QHP that will include an appeals process. I think it's always hard to take back power that you've ceded rather than to once you've given it up. And again, I'm pretty strong on this. I think that we need to keep that authority that the federal government has given us, rather than give it away and then hope we're going to get it back later. And I recognize, respect Mr. Kipper, and I respect what he's saying, but the exchange is a subset of the health insurance market, and we may have standards that are higher than the Division of Insurance. And I don't want to give away the ability to do that. And I don't want to give it away and then hope that 3 or 4 years from now, when we want it back, we can get it back. It's much harder to do that than to not give it away in the first place. So with due respect, I would disagree with Mr. Kipper, and I would move that we adopt recommendation E.
Ms. Atkins, were you wanting to make a comment?
No, I'm fine. Thank you, though.
All right.
This is Marie Kerr. I understand what you're saying about, as we were discussing earlier, about C and D, the Division of Insurance having the knowledge to and the personnel and the and the money to do the B&D, the certification and the recertification process. In terms of decertification, my alternate proposal is simply reading as follows. The exchange may decertify a QHP that ceases to meet the requirements of the exchange, comma, which is found by DOI, or Department of Insurance, to cease to meet Department of Insurance requirements, comma, or the Affordable Care Act and its regulations by majority vote of the board. The exchange will set up a procedure for decertification of a QHP that will include an appeals process. So basically, we take out the word, the Division of Insurance, and replace them with which is found by the Division of Insurance to cease to meet Division of Insurance requirements. So it's a compromise approach, if you will, so that we're not in conflict with any DOI ruling, and we're continuing to go with Dr. Klein's very thoughtful analysis, is we need to be able to control our own sandbox. On the other hand, we can't be controlling someone else's sandbox. So that's my alternative proposal.
The way I understood what you said, maybe I didn't understand it correctly, is we can only decertify a plan if they fail to meet if they fail to meet DOI or ACA requirements. If I'm understanding the verbiage, is that what your
No.
language says?
No.
Okay.
Basically, I was saying the exchange may decertify a QHP that ceases to meet the requirements of the exchange. So that's one basis of decertification. So that's our sandbox. We keep our sandbox. Which is found by Division of Insurance to cease to meet Division of Insurance requirements. So we're saying we're not going to conflict with any Division of Insurance findings or the requirements of the ACA. So we have basically two areas where the exchange decertifies with or without DOI input, and I certainly hope that if DOI gives input that we would listen to it. And then we have where the exchange may decertify based on a finding by DOI. And then we don't interfere with DOI's processes. So that's my thought on the matter.
This is Lynn Atkins. I think that sounds more like going away from, I think, the direction Dr. Klein was trying to go, which was retaining the authority to decertify a plan if even if the Division of Insurance says that the plan is a qualified health plan for the state of Nevada, that we still may want to decertify it if our standards change or our benchmarks change or something change. And so that sounds to me like it's going back as long as the Division of Insurance certifies it, that we can't decertify.
That's what I'm trying to listen, and you're reading what you're reading, but I'm not seeing that much difference between what you're saying and E. So I may be missing that. Again, I said it. My compliments to Ms. Johnstone, because she said it better than I did. I mean, I said it in a negative way, and she said it in a positive way. Somebody may completely qualify in the state. They may be a good player in based on DOI, but we have higher standards because fortunately we have so many people who want to play in our sandbox that we have to limit it. And so we choose, and we say, you guys are the best corporate citizens in the state of Nevada, and we reward you by doing that. So I guess I'm missing the way your language is different than E.
Here's the way it's different. Under my language, we're not interpreting DOI's regulations for them, which would put us in, I don't even know if we can do that, and that's why I was saying, has anyone done legal analysis of the statute, whether or not we can do it in this alternative way? Because I don't know if we can even do what's being put out there, or if someone has done a really thorough reading of that portion of, I think it's, and I'm trying to find out on the internet as we're talking, it's 45 CFR 1000 sub C, if we've had a very good analysis of that, to determine whether or not the proposal either proposal that's being put forth can even be done in the way that's being suggested.
Why don't we just cross out the Division of Insurance?
Yes.
So then it reads, because the presumption would be that one of the requirements of the exchange would be that you're certified by the Division of Insurance. So now E would read, the exchange may decertify a QHP that ceases to meet the requirements of the exchange or the Affordable Care Act and its regulations by majority vote of the board, and that way there's no conflict with DOI. Again, the presumption would be that we would not certify a QHP that wasn't certified by the DOI. In fact, I don't know even if we could. That way we eliminate that conflict. Does that work?
I think that makes sense, because if they've been decertified by DOI, then we certainly wouldn't then go and certify them.
That's what it's of our exchange.
But
yeah.
I don't know.
Johnstone?
This is coming out a little bit differently again. On the certification, that it has to meet, in my mind, DOI standards that are in conjunction with what the Exchange Board has set for the qualified health plan. So I would like to see that written as a mutual agreement on what those standards should be, and then have DOI do the certification. The decertification, I would view as those are the mid-year, those are the bad actors, and that's a DOI job. And the recertification goes back to the mutual agreement on what the standards are for certification, so that if in a subsequent year the Exchange Board wants to raise the bar, we do that mutually with DOI, and the decertification only happens mid-year by DOI for the bad actors, because I don't think the exchange is, unless we want to completely duplicate the efforts of DOI, the exchange wouldn't be in a position of identifying a bad actor mid-year and causing the disruption that we're talking about. I don't know if that makes sense or not, but that's where I would be coming from.
Mr. Hagan?
Madam Chair, I just want to be clear that the federal regulations very specifically say certification, recertification, and decertification is a requirement of the exchange. And so this, like the discussion that we're going to have on appeals, the fact that we're outsourcing to Xerox for the enrollment eligibility, all of the things that we are outsourcing, this is one of those items. So the Division of Insurance is acting as our agent to certify and recertify plans, and depending on how this discussion goes, potentially decertify plans. So they're acting as our agent to implement the standards that the exchange sets, that this board sets. And so they would, if they take this up, they would act to make sure that the carriers that are on our exchange meet the standards of the exchange above and beyond the processes that they have for plans that are not on the exchange. Now, if at some point we raise the bar so high that they say we're done doing this, it's too much. If we go to an active purchaser model, at that point, then we would probably revisit. We probably should revisit this to discuss how it should happen. But again, these recommendations, they're not to say that the DOI gets it and that's it. They are acting as our agent. It's an MOU that can be terminated with, I think it's 30 days notice, something like that. So I just want to be clear. We are simply outsourcing a task to the Division of Insurance so that they can act as an agent of the exchange.
Mr. Hager? Board members, I'm going to, we had asked Stephanie Cruz to come back on the line at 2:30, and I know she was delaying some meetings to accommodate our schedule. Do you mind if we break?
Madam Chair, I just had one final recommendation. This is Dr. Ford for the record.
Yes, Dr. Ford.
I think there is a way to thread the needle here, and my proposal, and we can hash out the language after the presentation, is that the DOI makes recommendations to the board regarding certification, recertification, and decertification with final approval by the board. So
I certainly think that's an option for us to talk about. I think it's a good one.
Thank you.
Great. All right. Do any of the members object to us breaking from this to go back to the marketing contract? Doesn't sound like it. So, Shauna, do you want to get started here? And Stephanie, you're on the phone?
Yes, I am.
Thank you.
Okay, for the record, this is Shauna DeRuse. Item number 6 was discussing the ratification of the marketing and outreach contract, and we had some questions from board members regarding KPS 3 and the activity that they had in the state of Nevada and specifically in southern Nevada. And so Stephanie Cruz, who is the principal of KPS3, is on the line to give us some background of KPS3 and perhaps talk about some of the campaigns that they have conducted in the state and her experience in Southern Nevada and what she looks forward to doing in that area for us. Stephanie?
Great. For the record, Stephanie Cruz, president of KPS3 Marketing. KPS3 has been in business in the state of Nevada for 21 years and has always operated on a statewide basis. Although our office location is currently only in Reno, we have had office locations in both Las Vegas and Reno for a number of years in our history. A little bit about some of the campaigns that we have done statewide, including public relations and advertising, creation and production and placement in all aspects of the state, including Southern Nevada, Northern Nevada, and also in rural communities. One of the more recent ones was a campaign called Go to College, and it was for the Nevada System of Higher Education. It targeted underserved teens and their parents to talk to them about the opportunity to go to college when they didn't think that they were going to be able to. Another fairly large statewide campaign was done for the State of Nevada Safety Consultation and Training Section, which is a section of the Division of Industrial Relations, and that targets both employees and employers on workplace safety issues. We have also a component of that really targeting Hispanic workers and also Latino-owned businesses. A more recent one, a little bit narrower audience, a statewide campaign for the State Division of Health and Human Services in conjunction with the Nevada Network Against Domestic Violence. It was a statutory rape campaign targeting young men 18 to 21. So some very targeted media placement, social media, non-traditional media. And then finally, some older ones. A few years ago, we were working with an insurance plan to market directly to state of Nevada employees across the state to reach them with information about their opportunity to sign up with that particular product. We've also done research and worked with a number of organizations, nonprofits, nonprofits, Nevada Immunization Coalition, federally qualified health centers, Nevada Hospital Association, in doing research with various populations in both ends of the state to find out more about what means things to them so that we can help them craft communication strategies to reach them and influence them. And so we've done a lot of work statewide in prior campaigns. Plus, our media buyer who joined us about 2 years ago has worked in other agencies that has done a number of extensive statewide campaigns. The media plan that we put together that is still part of our confidential technical proposal really addressed a lot of the questions you had about our understanding of media entities and how to reach the population that you're targeting. They don't always respond to traditional media, and the RFP specifically asked us to look at ways to reach the target population in less traditional means. And so we completed a very detailed media plan for phases 2 and 3 that targeted the percentage of uninsured population by geography and also by their level of poverty against the federal poverty level. So, and also with a very, very strong emphasis on the Hispanic market, since that was part of the RFP. We also have a number of ways to reach them in very non-traditional ways, which is why we partnered with Access to Healthcare Network. They are, I believe, the statewide nonprofit organization that has more experience, more day-to-day contact, and more understanding of the target audience that was designated by the RFP. They do outreach not only for their own product, which is really one small part of their offering. They do outreach for a number of state programs and have received contracts and grants to do that, i.e. Ryan White, SHIP, and a number of other programs. So they outreach many different programs, and through their many means of already being in contact and developing relationships with people who are at 100 to 250% of federal poverty level, they interact with the target audience and have built relationships with that population in Reno area, Carson City, rural Nevada, and for the last 2.5 years in southern Nevada. They have a Las Vegas office with 13 staff members and a very, very, very active outreach program for both their medical program, their dental program, and all of the other state programs that they represent. So to clarify your second question, what they would be doing is literally the outreach grassroots component of what was asked for in the RFP. They have the contacts, they have the relationships, and they already have venues both in person, through a call center, through brochure drops, through grassroots activities, and then through some very, I think, strategically creative ways of potentially reaching this audience. We feel that that outreach component is a critical component, and that this campaign needs to be much more than developing and placing ads, because that is not, it has been shown in other states not to be the most effective way to reach the population. So between with AHN and all of their partners that they have statewide, we feel that they have the best shot at reaching the target population either by phone, robocalling, door-to-door, or through one of their existing means like a call center or a kiosk that they have all over the state.
Thank you, Stephanie. Are there any questions from the board members?
Yes. Dr. Klein, are any of the other members down in Las Vegas, do you have any other questions for Ms. Cruz?
Yes, I do. Thank you, Ms. Cruz, very much. It's Lynn Atkins, for the record. I guess, I don't want to say anything negative about Access to Healthcare Network, because I don't know that I have a strong, I guess I'm just going to say what I'm going to say. It's my understanding that I think 2.5 years ago they were very successful, and I think are still very successful in northern Nevada, and that their entry into Las Vegas did not come to its fruition, was not as successful as they had anticipated or hoped. So I don't know if that has changed over the past 12 months, and maybe it has, and that would be great to hear, but that it was a little more challenging and difficult than had originally anticipated. And so I guess that's my first question. I have a few questions, but if anyone has any information on their success, their number of members, that's different kind of from my working understanding, that would be great.
It has. I'm very familiar with Access because we've worked with them on and off for years, and I know that in northern Nevada, their enrollment for their members went more quickly than their enrollment and their contracting with partners in southern Nevada. However, the other programs that they outreach on, the other state products and programs that they have contracts to do, have gone very, very well, and they are reaching the population they need to be reaching to help them understand about some of the other programs that the state offers that they have contracted with Access to outreach on. So, yes, I can't say that their membership increases have rivaled what they did in northern Nevada in their first year and a half, but what they are doing with the target population, I think, is incredibly admirable, and they are reaching who they need to reach in your target population, mainly the 100 to 150% of federal poverty level. And if they do reach someone who needs to be referred to Medicaid or some other product, they do that because it's what they do, and they know they need to serve their population as best as they can.
This is Ron Klein. And I guess it's sort of a corollary to what Lynn Atkins was saying, is that if access to the way it was presented and before you were here, so that Access to Healthcare Network was your primary focus, is your primary way of getting to people in Southern Nevada. And so that's why the questions came up into how much of a presence they have in Southern Nevada. So I guess first of all, the target population goes up to 400% of the federal poverty level in terms of the subsidies. So although there's a target population, it really does, it is sort of perhaps broader than you've expressed. But I guess the question would be, what have you done, not with Access to Healthcare Network, but you as an agency into the Southern Nevada media market to give us the comfort to say your agency, even though it's based in Reno, has experience in the Southern Nevada media market?
The campaigns that I listed when I first began were statewide campaigns with the dominant share of the media placement being in Southern Nevada. Because of the size of the market and the cost of media, typically the budget really is allocated much more heavily to a Southern Nevada market, even if it's a statewide campaign. The campaigns that we have launched, we've launched with varying budgets from $150,000 to $500,000 over the course of a campaign. This is a larger media budget, at least the way we would see it over the course of 12 months. But I think if I could say the very detailed media plan we put together that was part of the evaluation process demonstrated that we know the media market because of the selections that we made and how we allocated it by geographical area and by population. And again, we place with these media all the time. We've worked with Southern Nevada media on both a public relations basis, which is not part of this contract, but also on a paid advertising basis, and have done so for 20 years. We understand the Nevada market and how to reach various populations, and the reason that the media budget that we proposed was relatively high is because we realize that those in 250 to 400% of the federal poverty level is just about anyone who might be watching television or listening to the radio or driving to work and seeing outdoor boards or out of home or bus shelters or receiving an ad served up on their mobile apps. So there are a number of ways to reach the target audience, and we believe that access in Southern Nevada and Northern Nevada and across the state will be critical in reaching the 100 to 250, or maybe more to 200% of federal poverty level, and that our media program that we developed in detail with our work plan will reach the target audience effectively and reach them in a way that educates them during phase 2 about what's going on and then causes them to take action in phase 3. So we have experience in placing media and understand that market, and we've done so for 20 years, and our media buyer has done so for 10, with 2 with us and 8 with another agency in Nevada who also does media statewide.
Lavon Lewis, and I have a couple of questions. One, were you able to determine the results of the college marketing plan that you implemented? And were you able to attribute any increase in enrollment, particularly minority enrollment in the state, to your plan?
Yes. One of our measures was to actually drive them to the website that we created for the campaign that had more information on it, and we feel that for both the parent section on the website and the teens section of the website, in both Spanish and in English, the numbers of visits and the numbers of interactions with our website and the information that they received definitely did have an impact. And during the course of the campaign, there was definitely more increase reported by the schools for the target audience going to their counselors and their teachers and requesting more information and actually trying to take a step in the right direction.
Another question.
Ms. Johnstone had a question too.
Thank you, Madam Chair. I seem to remember the procurement rules, having been a state employee once before, that after the evaluation committee comes up with recommendations, there's really limited choices on how to move forward, almost to the point of having to start over. And maybe John could refresh my memory on that. And if that's the case, maybe additional information can be given to the board before the next BOE, and we could take action if we want to have it pulled before the BOE. John, can you refresh my memory?
For the record, John Hager. So the selection of the vendor is done by the RFP committee, who has all of the proposals and all the information in front of them. The decision of the board is to ratify the selection or to not ratify the selection. If the board chooses to ratify, we go forward. If the board chooses to not ratify, then we go back and reissue the RFP and go through the entire process again. So those are the purchasing decisions. The other thing I will say about this, and I was not on the RFP committee, but my understanding is that of the 8, there were others that were outside of Nevada altogether. So they weren't. Not only were they not in southern Nevada, but they weren't in Nevada at all. And then there were others that, while they were in Nevada or even in southern Nevada, they were non-responsive and provided a proposal that was 1/5 the detail of this proposal. So I think that's a large portion of why this vendor was selected. But yes, to your question about the process, if it's not ratified today, then we. Excuse me. If it is not ratified today, then the decision is delayed and we delay the BOE. If it is the decision to completely disregard the committee's recommendation to select this vendor, then we go back to the RFP process and start all over.
This is Marie Kerr. Did we, in the bidders, without asking too much information about specifics, did any of the other bidders based in Nevada have a partner that was comparable to Access to Healthcare Network in either? Okay, so, and I think that's an important question because they, nothing's going to be perfect, but we should go with the best that we can get or that is available. And, certainly if there's a Nevada-based entity that is, that can provide the service that we need, we should go with them. Without completely reopening the process. So there you are.
Madam Chair, Lynette Atkins, I have one question and I guess two questions. My earlier question about, I guess my big question is about the subcontract issue. I think I'm still confused about it, I guess. So how much of the $6 million budget is dedicated to subcontracting out with Access to Healthcare Network? That's my first question.
This is Stephanie Cruz for the record. May I ask, do you want me to answer that? Or
Stephanie, hold just a minute.
Okay.
We're still in a purchasing process mode where we can have protests, if I'm not correct. So we have to be very careful about what you're asking in the kind of detail that's given back.
And again, Ms. Atkins, this is Shauna Durs for the record. I can say that because we are retaining control of any work done through the work order process in this contract, the dollar amount that was in the proposal is not necessarily the dollar amount that would end up in those work orders. That is part of the collaboration that the staff and we will sit down and we will work with KPS3 to develop what they go forth and do for us. So the dollar amount that was actually in the proposal is not necessarily the dollar amount that will actually get paid out.
So, okay. So I guess my final question is, it sounds like from the initial presentation there was recommendations and references about KPS3. Did we also have recommendations and references about Access to Healthcare Network? And I say that, I'm assuming, did staff review that organization that's going to be a sub-grantee? Did staff review all the information on the website? There's an audit on their website which talks about discrepancies from other grants. And I'd love to have updated information before we enter into a contract and subcontract with an organization that I don't know how much the reviewers know about, and it just seems troubling to me.
Again, for the record, Shauna Drew, part of the RFP evaluation process is to review references on not only the principal proposal organizations, but also any subcontractors. So we did get references on Access to Healthcare, and we also got them on KPS3. And as I said before, actually, most, if not all, of the references that we got, the references come in on a 1 to 10 scoring level, and they were all very, very high and very complimentary. So we did get references on both.
And did staff review the audit that's on their website about prior grant discrepancies?
So part of the process is also the financial stability of the organizations, and we did review the financial statements of both organizations, and they were deemed to have been passed. It is a pass-fail situation, and they were deemed to have been passed. And that is an outside person from the RFP evaluation committee that actually does that process. So we get a report back that says pass or fail, and they passed.
Wasn't that a question?
If we had reviewed the audit. So to answer your question specifically, Ms. Atkins, no, I did not. I personally did not go out onto their website and review the audit or the findings, if there are any, on their particular website. I don't know about the other evaluation committee members.
All right, so what is the pleasure of the board at this point? Either we have to, we need to let John know if we should proceed to the Board of Examiners. If the board is uncomfortable, you have the option of not ratifying, and then we start all over again on an RFP process.
Can I ask a question? This is Ron Klein. How long is this contract for?
This contract would be from the January BOE through March of 2014.
I'm sorry, from the January. Oh, so it's a 2-year contract, 1-year contract, from 2013 to 2014.
Correct.
So okay. So I get 50. Yeah. How long? 50 March. Okay. So I guess if we move forward with this contract and time is of the essence, and we're unhappy with the performance of KPS3, and hopefully that's not the case, but if we were unhappy, then we could always obviously choose a different vendor a year later. And just to clarify, I think what the concern is down here, and I think we've said it pretty clearly, is that an awful lot of in what we're hearing, an awful lot of emphasis is placed on Access to Healthcare Network. And again, I'll say it again, I gave Access to Healthcare Network an award 2 years ago for their wonderful work in Northern Nevada. So it's not an axe to grind. Just that we see less of a presence down here in Southern Nevada, and yet at the same time so much perhaps correctly or incorrectly, so much of the detail behind the Southern Nevada effort is based on them. And I think that's the uncomfort, or the lack of comfort, if I'm expressing that correctly.
Dr. Klein, maybe this is, for the record, John Hager, to maybe allay some of those concerns. I think that perhaps, well, there's a couple things. I think we shouldn't put as much emphasis on that Access to Healthcare Network. That is the boots on the ground effort. However, my understanding from the other proposals, there was no boots on the ground effort at all. So it was either go with an organization that has that boots on the ground, and maybe they are better in Northern Nevada than they are in Southern Nevada, but they've got some presence, or to go with an organization and a proposal that did not have any boots on the ground. A majority of this contract is for the marketing and advertising, for the research, for the analysis, and for the placement of advertising, both traditional and non-traditional. That's where the emphasis is, and that's statewide. Absolutely, the Access to Healthcare Network component is helpful. It is that boots on the ground, but again, the other proposals, from my understanding, did not have that functionality at all.
Mr. Hager, and this is Lynette Kunsberger, I guess that would be, I guess that was the question that can't be answered. It would be great, it would be interesting if of the $6 million, $100,000 was being designated to this, although I guess that would be troubling, right? Because we would want more down here. So if so much, how much is being awarded to the boots on the ground in Las Vegas or in Southern Nevada? And since we can't know that yet or don't know that, it's really hard to make a recommendation. It's hard to assess, but it sounds like we're in a box.
Although we can
sounds
change,
like we can't.
we can change that. If we do, I mean, so I guess part of the question here is we're asking for details that we're told can't be given to us. So I guess the question would be, and not to micromanage anybody, but if we do award this 15-month contract to KPS3, then are we able to view the categories of spending, the geographic categories of spending, and are we able to alter it? Because Mr. Roos said that there are work orders that we place. So assuming we do ratify this, are we then able to modify how spending is allocated?
Absolutely. So first of all, let me back up what I was saying here. So yes, we can do that. Again, this is a contract for $6 million of authority. They are going to be work order processes. Assuming the board ratifies this today and the BOE approves the contract on January 8th, we intended to have a presentation with KPS3 on January 10th for that January 10th board meeting. And at that point, we would be able to not only show you all of the various details that were proposed, but then we could either provide recommendations or indicate that we'll provide recommendations maybe in February once we've had a chance to talk with the vendor some more and actually have some meetings with them to discuss where we think that funding should be placed, and if the board wishes it, we could even bring it back to the board to approve that funding allocation or a policy that pushes it one direction or another.
Okay.
This is Marie.
So
Okay, go ahead. We've got a couple people trying to comment here. Ms. Kerr, what is
Certainly, the state can audit dollars that we pay to any entity, right? And if they do have some sort of weakness in their internal controls, we have the power to audit them. And how often would we audit them if we were to make sure that there were no problems with the money that we spent?
Per the standard contract document, we do have the power to audit them. And again, with the work order process, as we currently do with our vendors, we assign a piece of work, a project, they perform that work, we approve that invoice, we pay for that invoice. So it's piecemeal, I guess, is a word to use there. So we will be monitoring this process every step of the way, and to point out one more time that the decisions haven't been made yet about what exactly Access to Healthcare will do or where the media placement will be. These are the decisions that we want to come back in, have our group sessions, and then bring those decisions in. So I think we do have a lot of control here over what is yet to happen in Nevada.
And if there were a problem with not performing, then we could say,
there is
okay,
a 30-day
your work order's not going to be
There is
paid.
a 30-day cancellation clause in the contract.
Dr. Klein?
Madam Chair, may I make a motion, please?
Yes.
Somebody, public comment, did you?
I think there's at least one hand raised here, and we don't know if you're opening up to public comment or not, so we're just...
No, I'm not going to open it.
Okay.
Okay. So I'd like to make a motion that we approve KPS 3 as recommended, but that the staff of KPS3 and the Health Insurance Exchange present to us at the February board meeting the allocation of media resources, both in terms of type of media and in terms of a geographic allocation.
All right, is there a second to that motion?
I'll second that. It's left for Johnstone.
Okay, we have a second by Ms. Johnstone then. Any further discussion or comment, Mr. Hager?
For the record, John Hager, and that is absolutely doable. We want to make sure that the board understands part of the first phase is the research function that will help us, assist us understand better where those resources will be allocated. So regardless of whether that piece of the project is done by the February board meeting, we will provide a report to the board, at least a preliminary report. And before we go forward with the major allocation of resources, we will make sure that we bring a report back to the board so that you understand where our dollars are being spent.
Any other comment before I take the vote? All right, all in favor of the motion?
Aye.
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 Any opposed? Motion carries. Stephanie, thank you very much for joining us.
Thank you.
Let's take a 5-minute break. All right, let's go back on the record, and we're going to go back to agenda item number 10, and it's the plan certification and management recommendations. And we were discussing item number E that had dealt with the issue of decertification. And during the break, I had the opportunity of speaking with our Deputy Attorney General, or Senior Deputy Attorney General, who had some thoughts for us that might open up some good dialogue for us. So I'm going to ask Mr. Marcher if he might offer some thoughts to us as we proceed in this discussion.
Yeah, just briefly. I mean, the way that when you guys were talking about this originally, it set off a lot of bells because there's a lot of state agencies that sort of do this already. I mean, where they have basically an entity, and I'll use, as an example where you used to work a little bit with the tax commission is that the tax commission employs hearing officers who hear cases. Those cases then are ultimately appealed to the full commission if the person decides to appeal it. And it would kind of almost like work the same way with DOI, using your standards that you create is the investigative arm and the initial arm that makes a decision about decertification, for example. Then that decision could either, depending on how your policy shakes out, then that entity could either appeal to the board, and then that case, then the decertification would be upheld, or maybe it could be modified a little bit somehow, or it would be overturned, or or you could set it up to where it's just automatic, that anything they do needs to be, any decision they make needs to automatically comes to you, and it has to be confirmed by you or overturned by you. I mean, it's just the way that you keep ultimate control of and are the final decision maker, but they're as your agent are doing all the footwork.
So Keith, would you, and again, stepping back to my old hat on the tax commission, could this be something that on a quarterly basis or semi-annually, that the Division of Insurance gives us a list of who's been certified, who's been recertified, and who might be decertified, and we could look at it even as simply as a consent calendar to say we concur with that, or we could have the listing of everything and members could say selectively, I would like to look at company XYZ, pull that off the consent so we can talk about it.
Sure, you can do that, and then like I said, the way other entities operate is that the appeals process, they get their due process in front of the DOI. Then if they choose to appeal, then you set up an appeals process where if they choose to appeal, they come to the board, and then you would hear that particular case. Okay? And if they don't appeal, then you don't have to do anything. I mean, that's one way to do it. Again, the other way to do it would be that everything that they do comes before you in the form of a consent agenda or however for final approval or modification, or you could overturn something.
Keith?
Yeah.
Because if we have DOI be our agent for decertification, could we direct DOI to initiate a proceeding for decertification?
I don't see why not. I mean, the thing, I think the disconnect to me is that it almost sounds like you're in opposing camps the way you were talking, but you're not. You're both doing the same thing. You're on the same side. They're using your standards to make a determination, and then you're going to look at the case independently if somebody appeals it. That's all.
This is Ron Klein, and I think we were talking down here as well, and maybe we're tripping up a little bit on our words in terms of certification, decertification, and maybe a better word is participate, in the sense that decertification has this negative connotation, and really what we mean is a positive connotation. So you're saying, sir, that there are the same standards, and I guess I would disagree and say there really are two standards, because there is the Division of Insurance standard that says you meet the minimum requirements to function, to sell insurance in the state of Nevada. That's one set of standards. And it's conceivable that if we're very successful, and obviously we hope that we are, and we have many people who want to play in our sandbox, that we say, well, you know what, all you guys have met the minimum standards, but of all you 10 who've met the minimum standards, we're going to pick 5. And so we're going to create a different set of standards, different from the Division of Insurance, that picks the best of the best and says you can be here. So there really are two different standards, and I guess I'm wondering if perhaps by using the term certification and decertification, we're confusing the issue in terms of somebody down here was sort of confused and thought that I was saying that we were going to decertify them from selling insurance across the whole state, which obviously the Health Insurance Exchange doesn't have that authority. But really what we're talking about is the ability to participate within the exchange, and if that's a better term. And I think Dr. Ford, I think, had good language down here that she said before, and that might find a happy medium. I don't know if you want to speak to that, or you want to say what you're.
Yeah. So this is Dr. Ford for the record. The language that I was working on was that the DOI makes recommendations on which qualified health plans would participate in the Silver State Health Exchange for board approval.
Yeah.
For the record, John Hager. So in April, the board approved the policy of going forward with a free market facilitator model, that any plan that meets the standards set by the board would be able to provide their products in the exchange. So and there are different standards theoretically between the exchange and the Division of Insurance, so let me back up. There are standards that are implemented by the Affordable Care Act for qualified health plans that are not implemented on plans that are offered outside the exchange. There are standards that the board may or may not set in the future. The Division of Insurance, in taking on this role as an agency that will certify, recertify, or potentially decertify, would be required to ensure that any qualified health plan meets our standards in addition to the market-wide standards. They will be, in this case, acting as our agent, as a branch of the exchange, if you will, for the certification function. The reason why we have recommended that they do that for certification and recertification, and I think staff originally recommended for decertification as well to the committee, was because they already do rate review. They already check plans to make sure they meet various requirements. So this would allow them to simply do that same process for our standards as well.
But as the Attorney General said, Deputy Attorney General, don't want to promote him just yet, said is you have the Division of Insurance doing the investigation, and I'm not familiar with the Tax Commission, but ultimately the decision rests with the Tax Commission, or perhaps I'm saying that incorrectly.
That's
so
correct.
I think, am I saying it right? Okay.
That you are correct.
Okay, I think all what we're saying down here is we want to work with the Division of Insurance. We want to use their resources. We want to use their expertise. We will listen to their recommendations. But at the end of the day, the final decision as to who participates in the health insurance exchange rests with the Health Insurance Exchange Board. That's what federal law says. And although we have voted to be a free market exchange, that may or may not change in the future, and things may change, and so I don't want to. Just as a basic rule of thumb, I don't want to cede power, cede a responsibility, whatever term you want to use, that's been given to us by federal law, and then try to claw it back 3 or 4 years from now. I mean, we should retain that authority that the federal government has given us.
I think I've come up with a way to wordsmith it so that we're matching what our Deputy Attorney General, the procedure which is followed by other state agencies, so that we avoid redundant proceedings. And I don't know if anyone has an idea of how much an investigation and hearing process costs. I think it's probably around the hundreds of thousands for a full insurance company. And I just don't think we've got the resources to do that every day. Anyway, so here's sub E. Allow the Division of Insurance, on behalf of the exchange, to decertify a QHP that ceases to meet the requirements of the exchange, the Division of Insurance, or the Affordable Care Act and its regulations. The exchange will set up a procedure for appeals of decertification by DOI, and the exchange may direct DOI to initiate a decertification proceeding so that we're in charge of the end product. So if there's a decertification that someone says, I want to now appeal, we are in charge of the appeal. And we also are, I don't want to say we're using DOI, but we're utilizing our agent so that if we find a bad actor and we say there's a problem, we initiate the proceeding. And if it comes out, if DOI doesn't come out the way we like, we are still in charge of the appeal, so that we can decertify if we don't like the result. So that allows us to retain our power to decertify bad actors, but also allows us to use the resources of DOI and the expertise, and certainly in the certification and the recertification process.
Do you want to repeat that again?
Okay, do you want me to reread the stuff that I just read?
The way I heard your verbiage, because I was trying to listen real carefully, we have the power to, or the authority to initiate a decertification procedure, is what I heard you say, but your language didn't speak to who has the authority to vote on that. Because I was trying to listen real carefully. And I heard that we have the ability to initiate a decertification procedure, but the first part of what you said that the authority to decertify rests with the Division of Insurance. That's what I heard. Maybe I misheard.
So the first part says the DOI has the authority to decertify. However, the next part says that we set up the procedure for appeals of decertification. So there is an appeal. We're the higher administrative body. If there's a decertification that goes, against the person who's been decertified. Also, if we want someone to be decertified and DOI has not initiated a proceeding, we have the power to direct DOI as our agent to initiate a decertification proceeding. And if that doesn't go the way we like, we then, because we have the power of appeals and we're the final administrative body, we have the, after it's initiated, if we don't like it, we can then say no.
Wouldn't Dr. Ford's statement that DOI makes a recommendation to the Health Insurance Exchange to participate to the board to the SSHIX board for approval? It just seems very clean language. It's saying the same thing.
So I'll email her back and.
Right. Whoever's on the phone needs to mute. We're hearing your conversation.
Like, oh my gosh. Okay, no. Yeah. So,
Hello, whoever's on the telephone listening to this proceeding, you need to mute. We're hearing your conversation on the telephone. Thank you.
Dr. Klein, for the record, John Hager, can I, just to make sure I understand, so the wording, or maybe this is for Dr. Ford, the wording that you are proposing says that the exchange shall have the final decision on basically paragraph C, D, and E, so certification, recertification, and decertification?
I think it ought to be all combined.
Yes, this is Dr. Ford. Yes, that's exactly what I'm saying.
With the advice under the guidance or whatever term you want to use under the Division of Insurance. I mean, again, everybody keeps getting caught up with the fact that trying to say that we want to do our own investigations. Nobody's saying that. What we keep saying here repeatedly, I keep saying repeatedly, is the Division of Insurance will investigate. They will make recommendations, but the final authority to certify, decertify, recertify, participate rests with the SSHIX board as per federal law. And I'm not going to give the Division of Insurance that, I'm not going to make them our agent to make that decision. I will make them our agent to investigate and do the groundwork, but the final authority to make that decision rests with us.
Well, that's another way to go, and it just saves a step in the process where, back to what I'm used to, is, the administrative hearing process is they go do the investigation and they make a recommendation to you, and you're just the final decision maker, and there's the appeal after that would probably have to be to court. So.
And there's a sentence in, and just so as not to micromanage, there's a sentence right there that says the exchange will set up a procedure for decertification of a QHP that will include an appeals process. So, Dr. Ford's language with that terminal sentence there as well, so that we leave the micromanagement of the process to SSHIX staff and DOI staff.
Let me make some suggestions, because I think that we will need the Attorney General to help us on some of this to make sure that we're not creating unintentional conflicts. Because I think Commissioner Kipper, when we were talking off the record, thought that this process was probably doable for us. I would like to see us take items C, D, and E and put them into one statement, like you had suggested, Dr. Ford. But I would like to get a little bit of help from the Attorney General to make sure that we're crafting it properly without creating conflicts. Is anybody adverse to that? We could bring it back in January. And then, Ms. Kerr, that might address your question of legal review on it. Because I think everybody's on the
We're
same
nodding
page.
here down south.
Okay.
Yeah, I mean, we can help you guys with that a little bit. And like I said, I've been in this arena for a while, and Dennis is your attorney for that purpose. But I can certainly work with them, and we can try and I'm going to be kind of gone on Christmas break, but when I get back, we can certainly get something together probably before January.
Your sentence was very good.
I think that we're all on the same page. I just want to make sure that in an effort to get this passed quickly, that we aren't creating conflict.
I think it's a great idea.
Okay. All right, then, listening to concurrence with the board members, we'll direct staff to work with the Attorney General in developing language consistent with what we've discussed here today, combining items C, D, and E in cooperation with the Division of Insurance.
And B.
And
B.
And B? Does B need to?
It needs to.
Okay. Yeah, Mr. Hager's saying B needs to be in. So we'll have one nice, clean statement then. All right. So we're going to close.
Recommendation
No.
6.
We're going to close recommendation 6 on plan certification and move on to recommendation number 7.
The Affordable Care Act and the regulations require that the exchange set up a timeline for accreditation by a national entity. So far, the Secretary of Health and Human Services has recognized NCQA and URAC as national accrediting entities. Accrediting is separate from certification. Accrediting is a quality test of the carriers, and basically provides us with a level of comfort that they're passing certain quality standards. So the recommendation provided on page 9 of the of attachment A is that we require that, the track changes used here are to show the differences between the original committee recommendation. The changes here are based on consultations with NCQA and URAC to make sure that we get this worded just right, to make sure it works. That we require that a carrier offering a QHP must either have a current accreditation by NCQA, URAC, or another accrediting entity recognized by HHS, or demonstrate during QHP certification evidence of a scheduled accreditation survey that will be completed within 24 months of the date of application for certification. Such accreditation must be for the product line being offered on the exchange. A carrier that does not receive accreditation within 24 months of the date of application for certification will lose their qualified health plan status following the completion of the plan year in which the deadline occurred. A licensed carrier that does not receive a satisfactory accreditation within the above timeline must be accredited before being allowed to sell QHPs on the exchange. The executive director or exchange board may make exceptions to this timeline if recommended by NCQA, URAC, or the Commissioner of Insurance. The exception line there was provided in case NCQA, URAC met with so much demand for their services that they couldn't get it done in 24 months. We don't anticipate that being a problem, but that's the main reason for that exception. And again, it would have to be approved. The exception would have to be approved by either myself or the exchange board, and we'd have to make sure that it makes sense for the exchange to do that. So anyways, that's the recommendation provided by the committee with some tweaks by staff.
All right, do we have any comments from board members on this recommendation? If there are none, does anyone want a motion to approve?
Madam Chairman, Lavon Lewis, I move approval of recommendation number 7.
Thank you, Ms. Lewis. Is there a second?
This is Dr. Ford. I second.
Thank you, Dr. Ford. Any further discussion? All in favor of the motion?
Aye.
Aye.
Opposed? Motion carries. Then on to recommendation number 8.
The Affordable Care Act and its regulations require that an exchange ensure that all qualified health plans meet certain network adequacy standards specified by the exchange. When we discussed this with the Division of Insurance, there was concern that if we specify a standard for network adequacy that is different from the rest of the market, there could be adverse selection consequences. Therefore, staff made the recommendation to the committee, and the committee made the recommendation to the board that the exchange require that that the exchange recommend to the state that network adequacy standards include standards regarding telemedicine and essential community providers. The exchange will adopt the network adequacy standards that are adopted by the state for the entire market, and the exchange will examine the network adequacy standards once they are issued. So again, the committee is recommending that we have a comprehensive network adequacy standard for the market that is recommended by the state, and that would be done through the legislative process. Currently, there are only network adequacy standards for HMOs. There are none for PPOs. So there will have to be some legislative changes. The committee felt it was important to include standards that include telemedicine and essential community providers. So that recommendation is being made to the Commissioner of Insurance and eventually to the legislature. Again, once those standards are adopted by the state, then we'd bring those back to the board for review.
All right, do we have any questions on recommendation number 8? Is there a motion to adopt?
Move to approve. Ron Klein.
Thank you, Dr. Klein. Is there a second?
Upon the second motion.
Thank you, Ms. Lewis. All right, any further discussion? All in favor of the motion?
Aye.
Aye.
Any opposed? Motion carries. Thank you.
Would you like to take them or?
There's no heading.
She's talked enough.
Well,
Consumer assistance.
okay. All right, the next item on the agenda will be the consumer assistance. And the first recommendation is recommendation number 5. Okay, and that's, yes. And Lynn, do you want to lead the discussion on this? Or do you want to?
I've asked him. I think CJ has agreed to, unless John wants to.
Okay. CJ, go ahead then.
Consumer Assistance Committee brought forth, they heard a plan for the enrollment and eligibility appeals to make sure that all of the consumers in the Silver State Health Insurance Exchange had adequate appeals methods for eligibility and ATPC enrollment issues. The Consumer Assistance Committee looked over the different types of appeals that we will have and the estimated numbers. If you look at page 7 of 17 on the attached report, we're looking in the first year of 141,000 enrollees. That's going to be termed down with the expansion of Medicaid. That's going to go to approximately 114 to 118,000 enrollees in the first year with the Medicaid expansion. And we're going to look at approximately 91 hearings that come out of the appeals, and that's about 8 a month. So we're going to have a total eligibility or ATPC appeal of numbers of subsidy that people are eligible for or eligibility for a different tier of cost sharing in about the 3,000, 3,050 range. In the next years, it's going to increase on a hearings basis to about 115 hearings and then up to 128 hearings. The FOSS system and the contract with Xerox has a very robust system put in place to handle all eligibility Tier 1 appeals. Anything that comes through, Xerox has a list of requirements and responses on how they will hear and adjudicate those appeals, gather information, and make sure that they get the right answer. That would be a Tier 1 appeal. Anything that comes through and is appealed at one point in time is a Tier 1 appeal. Xerox can hear that appeal, listen to it, and issue a decision. At that point, if the consumer appeals Xerox's decision on that matter, it would become a Tier 2 appeal, and that would move up into a formal hearing process. The Consumer Advisory Committee looked at 2 different options on a formal hearing process. One was establishment of a formal hearing process in the exchange. If you look at page 12 of 17 and 13 of 17 in the attached report, we can see the in-house hearing department budgets. To address the caseload that we've set forward in this report, we would require 2 positions that will cost the exchange approximately $151,000 the first year and $147,000 every year thereafter. Each appeal in this situation would cost the exchange approximately $1,600 in 2014, $1,230 in 2015, and $1,130 in 2016. That's option number 1. Option number 2 would be to contract out with the state agency. In this report, it leans to the Department of Administration Hearings Division. They have a process, hearing officers, and offices set in place to handle this. They handle numerous appeals through different agencies throughout the state, and we looked at some preliminary numbers from them, and they are looking at an approximate billing of about $200 per appeal that they hear. That's based on an hourly rate and a cost-sharing agreement that the exchange would have with the Department of Administration. If we assume the hearings, at least initially, are based on the numbers that we have, will be more complicated and take more staff time than the average $200 appeal, we've allocated about $300 per appeal, and based on the number of appeals estimated back in Figure 5, staff estimates it will cost approximately $40,000 per year for the Department of Administration Hearings Division to handle the appeals in the exchange. The recommendation that the committee made was to approve the plan for enrollment eligibility appeals in which Xerox State Healthcare LLC adjudicates all Level 1 enrollment and eligibility appeals, and the exchange contracts with the Department of Administration Hearings Division to adjudicate all Level 2 enrollment and eligibility appeals.
Thanks, CJ. Lynn Atkins for the record. And if I could just, I think the committee, let me start over. I think one of the biggest first level appeal issues is going to be the income verification. At least that's what we're talking about. So just to kind of walk everybody through what we think is going to happen. Maybe more frequently than we think, just because of wage issues here in Nevada. But that when people do go online, they fill out all the information. It goes back to the federal site to do income verification. It's going to have about a year and a half old information on income. So for people to have accurate information qualifying for a subsidy, if they are now underemployed or making less money that would qualify for them for a subsidy, it may come back saying you're not eligible for a subsidy or you're only eligible for a partial subsidy. The consumer might think that they should either get a subsidy or get more of a subsidy. They would have to provide Xerox with updated income information to be verified. And that, we think, is probably going to be the bulk of the first level appeals, complaints, whatever words you want to use. And hopefully most of those will be resolved with current income verification. So that's kind of the first level issue that we see happening. But yes, I think the committee was very concerned. I think we had one dissenter, however, who really wanted to keep the appeals process, the formal hearing process, in the hands of the exchange and have us actually do all of it. Hiring the appeals officer and really developing the infrastructure for an administrative appeal system, which just for the rest of the committee members just did not make sense. Just with all the notices and all the due process and everything that's already established in the Department of Administration, it just did not make sense financially with everything that we also that we're also working with now. So that's kind of just a few more pieces of information on recommendation 5.
All right, do we have any comments?
Is it Ron Klein? Ron?
Go ahead, Dr. Klein.
Oh, Judge, it's just sort of a tangent thing, but just a very quick question. Where are we in terms of the IRS and real-time verification of income? I just made me think of it as we were talking about this.
Same place we were last time. We'll find out soon. Yes.
Soon? Okay.
Yeah, we have continued to push. There are calls with IRS, CMS 2-3 times a week. It comes up regularly. The latest guidance, again, is that they intend to be real time, but they can't tell us what that real time is. Yeah, so.
Okay. Ms. Johnstone? Thank you, Madam Chair. This is Leslie Johnstone. I'm going to lean heavily on the experience with the state employee benefits program, where eligibility for the program is deemed to be pretty black and white. There are rules written down and time frames established with those rules. And I would see the exact same thing with eligibility for being on the exchange and the determination of the subsidy. So I would not like us to see going beyond the level 1 appeal process. I think the consumer's got every right to bring forward additional information to be considered, but that ought to be something that can be handled at the level 1 level by Xerox, and that there isn't really a role for a hearing officer. It's not a subjective eligibility criteria that's going to be in place. So to me, I think that we will get what we need in the protection for the consumer if we provide one level of appeal but not go beyond that.
Yeah, this is Lynn. That sounds great, and I think there's also a lot that needs to be figured out about the details of all this, about the time turnaround on these requests and not letting things languish at Xerox, and from the time a consumer actually submits additional income verification or citizenship verification, whatever it may be, that there are specific turnaround times, and I think all of that still needs to be worked out. But this is the framework. But I agree with you.
So just to be clear, this is Leslie Johnstone. I would not see us moving forward with a contract with Division of Administration to handle level 2 appeals.
He doesn't want it?
I'm sorry. I think a couple of us misunderstood you. I apologize.
Contract. You don't want B.
I think it's such a black and white decision once the information is made available that it should be handled at the administrative level with Xerox.
For the record, CJ Bowden, we agree that most of the things will be black and white and be able to be taken care of on the tier 1. We have to have a process in place to deal with the phase 2 when we get to a point where there is an actual appeal of a specific bill, or an example would be a court order in a divorce where a husband has medical payments that he needs to make for the children and the wife can claim them on tax returns. That's going to affect the ATPC received on both sides, and that would require a larger process to vet that appeal and make sure that everything is handled. This would be just for that secondary level when it wasn't adjudicated through the Xerox claims or the Xerox appeals segment. It would move up to a Department of Administration hearing.
Well, with all due respect, I see that as a black and white eligibility process as well, that you would have timeframes around to address that. I wasn't talking about appeals on claims payment at all, just speaking to eligibility appeals.
Is that a federal government requirement that we have 2 levels? Somebody? CJ, John?
For the record, John Hager. So there is actually no requirement to have an appeals function with the exchange.
This is Marie Kerr. If we don't have a second level of appeals, and maybe Mr. Marcher can help us with this one, if there's a first level denial by Xerox, the person who's denied, if they don't have to go through a second administrative step, isn't their next step going to court and suing us, costing us a lot more than $200 or $300?
Yeah.
Yes.
I would agree with the recommendation for B, and I guess maybe just a PR kind of a thing, or a perception kind of a thing. I hate to have Xerox, be viewed as the arbiter of somebody's health care rights. I'd rather have it be an administrative law judge do that. I think it looks better than having Xerox decide, who shall live and who shall die.
This is Dr. Ford. Does it cost us anything to contract with the Department of Administration? Isn't it a case-by-case fee?
Yes. Again, the Department of Administration has indicated that the fee is approximately $200 per appeal. In our budget, we have upped that to $300 simply because this is new, and there will probably be things that they are not used to hearing, so it might take some time to ramp up.
Right, but there's no fee to contract with them.
No.
Not retainer.
And this is Lynn Atkins, and I think also there's other issues besides this particular issue. Just another example is if somebody submits an application maybe on the last hour of open enrollment, but for some reason it doesn't get to the exchange, or there's some computer snafu and they're denied because they weren't doing it during open enrollment. I mean, if Xerox kind of says, well, sorry, you're out of luck, that person is going to probably want somebody to look at it again. And I just think you have to have that second step available. Otherwise, I agree with Ms. Kerr that we're going to see litigation.
Lynn, this is Barbara. Was there any conversation at all about a potential conflict of interest with Xerox doing the administrative step? I mean, since the whole system's built around them and their creative architecture of how this is supposed to flow and everything, and then they're the ones that you appeal to if you feel that it's been done incorrectly.
Yeah, I don't think so, because I think we really saw that first level as maybe information correcting. So somebody, when the information goes to the federal government and it comes back, if it's something that the consumer says that information is outdated or inaccurate, let me supply you with new information, that information is then going to be inputted into the computer system. And so I don't think any one of us saw that there was going to be subjective decisions being made by the Xerox staff. It really is more of a information clarification on the eligibility information that's being put into the computer system. That's.
It speaks to the point of why having a second level, administrative law judge is so important, since there is a perceived potential conflict.
Yeah.
All right, do we have any other discussion? What's the pleasure of the board on recommendation 5?
Lynn Atkins, for the record, I'd make a motion that recommendation is approved as stated on page
14.
We're going to do 14 or page 14 of 17 of the recommendations.
Lavon Lewis, I second the motion.
Okay, we have a motion and a second to accept the recommendation. Any further discussion or comments? All those in favor of the motion?
Aye.
Aye. Any opposed?
Opposed?
Okay, we have a one opposed and the balance of the board in favor of the recommendation. And let's move on to recommendation number 6.
Recommendation number 6 is to extend the hours of operation of the call center. The request for proposal 2023 for the business operations solution released March 26, 2012 required all submitting vendors to include call center operations 24 hours per day, 7 days per week. During negotiations, those hours were pared back to 8 a.m. to 6 p.m. Monday through Friday and 9 p.m. to 1 p.m. on Saturday. In November, the Consumer Assistance Advisory Committee recommended the contract with Xerox State Healthcare LLC to extend the hours of operation of the call center to include evenings and Sundays. Staff is currently working with Xerox to determine the cost of impact of the change, and the information will be provided as an attachment. I think Mr. Hager has a little bit of that information for additional cost.
For the record, John Hager. So Xerox has provided us with an initial proposal just to give the board an idea of the cost. So when the committee recommended to extend the hours to nights and Sundays, Xerox provided a proposal to have the hours on Monday through Friday go from 8 a.m. to 8 p.m. So extend it 2 hours on Monday through Friday, go from 9 a.m. to 3 p.m. on Saturday, so an additional 2 hours on Saturday. And then on Sunday, also be open from 9 a.m. to 3 p.m., so an additional 6 hours on Sunday. They've indicated for open enrollment 2014, for that 6-month open enrollment, they expect the cost to be approximately $560,000, and for the open enrollments after that, about $250,000. So those are the expected costs. We would have to work with them to determine an appropriate way to make that work, whether it's a lump sum or a per member per month fee. Additionally, if we were to do this, it would require an amendment to the contract. It would have to go to BOE to do this.
Okay,
for the record.
just a moment. Ms. Johnstone?
Just out of curiosity, why is it cheaper to extend the hours in the out years than the first year?
The later years are cheaper because the open enrollment only goes from October 15th through December 7th, so less than 2 months, whereas it's a full 6 months for the first one.
Ms. Atkins, were you? Or is it
Yes,
Dr.
yes.
Ford? Oh, okay.
Lynn Atkins for the record. I guess the threshold question for the board, I mean, the Consumer Assistance Advisory Committee felt very strongly that the current hours that we're contracted with were just not enough in Nevada. So that is why we kind of took the step, even though we weren't asked to make the recommendation to the board. So I guess that's the threshold question that the board needs to address is, are those current hours sufficient? And if not, do we incur the expense?
John, do you think, I mean, the number sort of I have nothing to compare to. Does that seem like a reasonable number based on the amount of staff? You assume that as hours got later, there'd be fewer people, you might need fewer employees to staff it, but I mean, does that number seem reasonable?
For the record, John Hager, yes, we did some initial calculation. It seemed reasonable considering the training that would be required as well as the additional staff and hours. We think that these calculations are appropriate. I wanted to be clear that the committee's recommendation was to extend the hours. There weren't into nights and weekends. There wasn't any other than that. There weren't any specifics. This proposal from Xerox is only to extend the hours during open enrollment. It does not extend hours outside of open enrollment, so there would be additional cost if it was the board's desire to extend those hours beyond open enrollment. Obviously, open enrollment is where we're going to have the greatest demand for our services, and that's why Xerox came back with this proposal.
If we get this completely wrong and there aren't as many phone calls to Xerox as we thought because our computer portal is so wonderful. Do we get money back? Do they let go people, or do people sit around and eat candy bars while they're waiting for the phones to ring?
Xerox has provided an initial staffing plan, and there's some things that we're working through with that staffing plan to make sure that we are all on the same board with the requirements to meet the demand that we have. Generally, it has been staff's stance that Xerox will meet the requirements because there are service level agreements that they have to meet. But that said, there were some concerns about the staffing levels, and so Xerox is going through and providing us with the math behind those staffing levels. I don't think I answered the question yet.
No, I'm saying the opposite. I'm being an optimist. I'm saying that there aren't as many phone calls as we thought.
I'm sorry. So yeah, I lost track of the question. So the simple answer is no. We would not get money back unless the demand was decreased and we had fewer enrollees. Then we'd pay less, obviously, which nobody wants, of course. However, the staffing plan that they have provided, it sets a base amount of people to answer the calls that we expect to come in, but it also has expansion. There are not only is there going to be a call center with people staffed there, but there will also be people in other call centers or at home that can receive overflow calls. So I think that and they've got a lot of experience doing this with other call centers for other operations. They are setting a base staffing plan to handle normal demand. The increased demand, the increased flux will probably happen at certain times, and they've got plans to handle that increased flux as well. But no, I think the short answer is we don't get money back if the demand is that much less.
Is there a way of negotiating it on a maybe month-by-month basis or something so that we're not throwing money away or an hourly basis?
There's always ways to work on the contract to make it work. One of the directions that we have gone with this is to outsource most of our functions. This puts the risk on the entity that is doing that function. So we have put a lot of risk on Xerox to absorb their costs. And so we have to make a judgment call on whether or not it makes sense to not only put that risk on Xerox, but then to meet those service level agreements, but then to also expect to give backs when that demand is not met. But we can make contracts any way you want.
Yeah, I mean, the art of a change order is you make up for a loss that you didn't anticipate some other place. So, I mean, that's the reality of it. So I think Dr. Klein's question is a good one. This is an area to recapture some things now that they're well into the process. So I guess I don't know. What's the pleasure of the committee on the recommendation itself, and then maybe some recommendations to staff on the amounts?
Okay. I would, go ahead.
This is Leslie Johnstone. I was going to support the recommendation with some direction to staff to try to limit our exposure if this is way a lot higher than what we need by way of resources. So some kind of quick out clause on this expanded service level if we deem that it's not necessary.
Is there a second to that motion?
Yeah, I was going to combine two motions. It's Ron Klein. I was going to move to accept the motion that Mr. Hager informally made, or that what he's negotiated with Xerox, and incorporate Ms. Johnstone's recommendation that we have some kind of out clause there, or variable clause in there that we can bring it back down if we find the need isn't there.
So it sounds like you're saying you'll second her motion. Is that correct?
Yes. Okay.
Okay. I didn't know if you were trying to amend it. Didn't sound like
I
there
wasn't
were
clear if she was
amendments
making a motion. I'm sorry.
Okay. All right. So we have a motion from Ms. Johnstone and a second from Dr. Klein. Any other comments on this recommendation? If not, then all those in favor of the motion?
Aye.
Aye.
Any opposed? Thank you. Let's move on to recommendation number 7.
For the record, C.J. Bowden. Recommendation 7 is approve the plan for navigators, enrollment assisters, and producers in the exchange. The Consumer Assistance Advisory Committee has worked since May on the plan for producers, navigators, and enrollment assisters. Enrollment assisters have taken various forms throughout the plan. Moving forward, the biggest changes that have been put in place are changes to the budget and changes to the responsibilities and roles of each. Looking at page 16 of 18, we have 3 distinct categories of in-person assistance that a person can go to and seek enrollment in the exchange in a qualified health plan. Those are all trained and certified. They're going to go through training and certification through the DOI. Producers, of course, are licensed producers by the Division of Insurance. The navigators and enrollment assisters will go through an exchange enrollment facilitator certification, an EEF. And what that will do will make sure that each person that is enrolling individuals in a qualified health plan on the exchange has the proper training and knowledge to be conducting those activities. Moving into the individual categories of in-person assistance, we have navigators. They're going to participate in education, outreach, and enrollment of individuals in the exchange. Navigators will be compensated through grant funds derived by the operations of the exchange, not the establishment funding grants from federal sources. The biggest responsibilities, as I said, education, outreach, and making sure that they support consumer appeals in a linguistically and culturally appropriate manner. Enrollment assistants will be limited strictly to enrollment. They will not be doing outreach nor education. They will have an EEF certification issued by the DOI. They will not receive direct or indirect consideration from carriers, and they will all be appointed by the exchange. They'll be compensated through competitive grants awarded by the exchange, though these funds will come from the federal establishment grants for the exchange. And their responsibility, sole responsibility, is going to be enrollment of individuals and employers in QHPs. Enrollment assisters may also not receive any direct or indirect consideration from carriers. Producers are licensed agents and brokers within the state of Nevada. They are going to go through a continuing education credit to get an exchange certification. They are going to enroll, educate their people that come to them in the same manner that they do today. They're going to be compensated by the carriers through the exchange. The exchange is not going to be in the middle of that transaction. They're going to be compensated directly by the carriers, and they're going to enroll individuals in QHP. They're going to do one-on-one education, support consumers with appeals, complaints, and service after enrollment in a QHP. There's a small graph on page 17 of 18 going on to page 18 that outlines those. I'd like to touch on the budget for proposed in-person assistance. The budget for enrollment assisters has been increased throughout. You can look at a graph on page 13 of 18 that outlines the budget for enrollment assisters and for navigators. With the expansion of Medicaid, the exchange first-year enrollment is going to decrease, and that decrease will be taken out of enrollment assister funding. It will not be taken out of navigator funding when the enrollment decreases. At this point, the recommendations to the board are to approve the navigator, producer, and enrollment assister report. I'd be happy to take any questions.
Lynn Atkins, for the record, if I may just add one thing. Yes, the entire report is attachment 10C? 10C. Yep. The recommendation on the pending board approvals on page 14, A, B, and C. A should actually also say outreach and education, because that's the big difference between the navigators and the enrollment assisters. Just for a real clear, the real clear difference between all of those. Because right now A and B are showing the exact same things. So A needs to also add outreach and education responsibilities. On page 14 and 15 of the pending board approvals, just the summaries of all of them show navigators and enrollment assisters as the same thing, and we need to add the outreach and education to navigators. So yes, there was a lot of discussion about this as well, and really trying to utilize the Affordable Care Act funds in the best way possible to have most boots on the ground, especially during the first open enrollment period. The enrollment assisters could not be the same as navigators. It needed to be different, so we decided to really narrow that role to really just enrolling, and between the marketing and outreach budget and the contract that we'll be entering into in January with the navigator, and additionally with the navigator budget, that we thought this was a best use of all of the funds that are available to us without increasing the per member per month fee.
Thank you, Lynn. This is also the one area where I was taking a head count to see if anybody wanted to have public comment on any of the advisory recommendations. And this, we had the one person say that they'd like to have public comment on this recommendation. So if you want to come forward, please.
Got it. Thank you, Madam Chair. For the record, I am Trey Abney, representing the 2,500 employers and 90,000 employees at the Chamber of Commerce of Reno Sparks in Northern Nevada. And we thank you for your hard work on this issue, and as we enter this brave new world of health insurance exchanges. And you know, we've been engaged on behalf of our broker community since the beginning, and been working with the Consumer Assistance Committee on this issue. And our main concern has always been, and we've had several meetings with Mr. Hager and others, is how producers, our private sector broker community fits in to this model, and how, you know, since we already have a robust private sector broker community in the state that have already been giving advice and know the insurance industry in and out, how that fits in with now bringing on a bunch of new navigators and enrollment assisters and how they interact with each other. And so we're supportive of everything that's gone on so far, and you've been a letter's been submitted to you that included my name on it and several names from the Nevada Association of Health Underwriters, NAHU. Just a couple of issues that we're still concerned about, and I want to make sure that we clarify. The Consumer Assistance Advisory Committee has decided, and again, by federal law, that the assisters and the navigators cannot give advice. They can enroll people and take down all the information, but they are prohibited from giving advice. And so we know that is difficult to enforce, and it's been stated as such. And as per the letter that we submitted, we just want to make sure that there are programs in place to make sure that is enforced. And you've seen examples in the letter, including secret shopper programs, recording of phone conversations, scope of appointment forms, so they are very clear on what they can and can't do to make sure that's clarified. The other issue, frankly, and all this, again, the point here is consumer protection. We want to make sure consumers are protected and the information they're given is accurate. And that's why the broker community is so important, because they have that constant communication with their customers and their clients. It's not a one and done deal. They don't just sign up and then go away. If you have any questions, you can call these people and these brokers and understand how the process works. On any discussions that have to do with fee per enrollment, whether they're going to get paid a fee per enrollment or for hourly, we would support the hourly model. We think if you pay a fee per enrollment, it encourages quantity over quality, if you will. And so, since they can't give advice, there's a danger in paying them for every policy that they bring in, and then where do all those consumers go if they were signed up so quickly through the process? Again, it's that customer contact and that customer follow-up. And so that's all. I won't take any more of your time at this very long meeting, but just wanted to bring your attention to those points. And again, thank you very much, and to the Consumer Assistance Committee for all their work on this. Thank you, Madam Chair. I appreciate it.
Mr. Abney. All right, we'll open it up again now for discussion with board members.
Madam Chair, we do have one person who would like to make public comment in Las Vegas.
Okay, thank you.
Good afternoon. This is Elisa Caffaretta with Nevada Advocates for Planned Parenthood Affiliates. And I just wanted to, first of all, thank the board for their months and months of work to refine these roles and the funding streams and the work to make sure that we're going to have the outreach to the community that we need. One of the things that we did discuss earlier in this process with Trey and some of the producer representatives was that it will be important for us to get probably some input from the producers. They could help us develop some guidance on situations where navigators and enrollment assisters might want to refer to a producer, just so that we all kind of have some guidelines that we can work from. I think that the folks that I've talked to that are interested in these roles of navigator and enrollment assisters are very interested in making sure consumers get the very best recommendations and care that they can get. And so we would like to work in partnership with the producers to, consider some of the situations where it might make the most sense to refer folks to producers. So I think, that at least is a conversation we've had. We want to make sure that's on the record going forward. And I would also then reiterate my comments, which I can't remember which meeting I made at, that once we bring the marketing organization on board, when we're thinking about the training and education, the conversations that are going to happen, it might, again, be very important to have some kind of a strategic planning conversation or guidance on how all of these pieces, the marketing dollars, the marketing boots on the ground, navigators and enrollment assisters, as well as producers, are going to work together, so that as you have struggled to sort of define how each piece works together, we all kind of get a chance to hear sort of an overview of how that all works. So again, we really appreciate all your work to make this a workable process for everyone and our clients. And we're looking forward to participating going forward. And we support the report as it's come forward. Thanks.
Thank you.
Thank you.
I'm just going to remind everyone it's a little past 4:30, and we think in Southern Nevada they may cut us off right at 5 o'clock. So I don't want to do that before we have our final public comment. So do board members have any other comments or anything that they want to say about recommendation number 7?
I have a question, Madam Chair.
Yes, Ms. Johnstone.
This is Leslie Johnstone. I really kind of got hung up on the statement that the EEF certification requires statutory changes and the timing of that. To get that certification in the requirement in the statute and then to get all of these folks through the certification and have everybody be ready to go October 1st? Is there confidence that, because a lot of times statutes don't get finalized until May, so.
That is certainly a concern. The bigger concern, of course, is if the statute didn't get through at all. And we, in speaking with the Division of Insurance, the division needs to make sure that that the people that are enrolling our consumers are trained and certified, and so that is very clear. The problem, of course, is that there is no Navigator or EEF certification in statute. The only thing that you can have is a producer license, and that's expressly prohibited for our Navigator program under federal law. So we definitely need a statutory change. The issue, of course, is it gets approved, say, last day of session, June 4th, and then we go forward. We will be working on implementing the project before the bill is done. We are already starting on the planning process and the training process. In fact, as we discussed earlier, staff is going to the broker training next week. But in our training plan that we've been looking at, we've been working with Xerox, Division of Insurance, going through it. The certification itself is relatively short, and then there will be some additional training by the exchange, the web portal, navigation stuff after that, and that portion of it, we're trying to bump it up as close to October 1st as possible, so that it's fresh in everybody's mind. That said, we want to make sure that we have enough time to train everybody. So there are going to be multiple training sessions going on day after day, probably for 2 or 3 months straight. It is a concern. We're working on it to make sure that we've got a good plan in place.
If that legislation didn't go, Ron Klein, if that legislation didn't go through, would producers be the only ones able to enroll in the exchange?
Yes, we'd have a problem at that point, because we wouldn't meet the requirements of the Affordable Care Act to have navigators, but producers by state law would be the only ones that could enroll.
Commissioner Kipper?
For the record, Scott Kipper, I think we would have to get extremely creative. We have a couple of tools at our disposal that we certify or license individuals, such as consultants, that they're not considered producers. There are, well, I guess what I'm trying to say is there are options, but first prize for us certainly would be a change in legislation. The process that's used is there are a number of small vendors in the state that do the training. They submit their reviews and their course work to us for approval. So that's the process that John was referring to in getting started early. I think once the board makes this approval, once the legislation is dropped, that we will see vendors starting to work on developing class work, class projects. At the same time, we'll start working on making sure we're able to implement this at the stroke of the governor's pen.
Ms. Johnstone?
And just one other maybe minor question. On the last page, page 18, providing culturally and linguistically appropriate health insurance enrollment assistance is only designated to the assisters. Why wouldn't the navigators and producers also provide the enrollment assistance?
That actually should be under navigators. The producers are not. Producers are going to continue in the same manner that they go forward now. If they happen to be bilingual or happen to serve a client that is in that that is specific to a certain culture, then so much the better. But that is not a requirement. That is a requirement of the navigators. That should have been an X in the navigators function. As far as in the enrollment assisters, oh, wait a minute.
No, this
I guess
is
we've got
fine. I
that
think I think there's two culturally and linguistically appropriate categories. One is for education, which is for navigators, and one is for enrollment assisters. But I do think that the education needs to be for navigators, and the enrollment assistance needs to be both for navigators and enrollment assisters.
Yeah.
Thank you. Do we have any other questions or comments? And what is the pleasure of the board?
This is Lynn Atkins. I would move that we accept the navigator enrollment assisters and producers 18-page document with the addition of an X in the navigator box on page 18 under culturally and linguistically appropriate enrollment assistance.
This is Delon Lewis, and I second the motion.
We have a motion and second. Any further discussion? All those in favor?
Aye. Aye.
Any opposed? Motion carries. All right, thank you all.
We're all happy down here.
Yeah, good. One more thing, John.
Oh no, I did not have no.
Oh, no, yeah. Discussion and possible action on updates to the exchange staffing plan.
For the record, Shauna DeRuse. Coming on the heels, this is a very timely discussion, coming on the heels of talking about the training needs and the hearings and appeals officer that we talked about earlier. When we were contemplating the fact that we may need to or want to work with the Department of Administration, then we looked at our current staffing plan that had a hearings and appeals officers in it, and we felt that that might not be the best fit. And we took a look at how could we still utilize this position. We are running very, very lean, and we didn't just want to toss out a very needed position. And we felt that a training officer would be a very valuable addition to our staffing plan. Just very quickly, this would be a cost-neutral change. This is the same salary step and grade range. It is based on a training officer 2 for the state of Nevada in the classified sections. So the duties as listed here are very similar to that. And I think that one of the things that this is, we've talked about training the navigators, the enrollment assisters. We've talked about having producer training. We also have about 2,000 welfare employees that need to be trained in utilizing the exchange. We have a big process ahead of us next summer. And so this particular position could help with that. They could do the trainings. They could help create the training. They could then look at the training afterwards to see, how it happened, reviews that we got, and how it could be made better. So very quickly, the duties are there. If you have any questions, I can answer them for you.
Do we have any questions for Shauna? Doesn't sound like it. All right. Everybody's starting to get tired. Do we have a motion to accept that update?
Motion to accept.
I'll second.
Second the motion.
All right. We have a motion in 3 seconds here, it looks like. All those in favor of the motion?
Aye.
Any opposed?
Aye.
Motion carries. Item number 12, dates, times, and agenda items for future meetings. I think that we've all been getting emails on what those are going to be for calendars over the next year, and we'll get those posted on the website as soon as we get confirmation.
The next meeting is scheduled for January 10th at 1 p.m. I think the location is here. I think it's the same locations. I'm not sure about this. I'm not sure about the south if it's the same or not. It is.
It is.
Okay, so
It is.
so both
It's down the
both
hall.
down the hall.
It is
But pretty
down
close
the hall,
to the same
that's where I
location.
showed up yesterday.
Okay, so pretty close to the same location. It will be here 1 o'clock on January 10th. After that, we have scheduled board meetings for the first Thursday of every month for calendar year 2013. We sent those as separate invitations to the board in case we wanted to move them, we didn't want to mess up the reoccurring thing. So the adoption hearing will also be held concurrently with the board meeting on January 10th.
Any requests for anything to go on the agenda by board members? Okay. All right. Agenda item 13 is public comment. Do we have anyone in Las Vegas that would like to use public comment?
Everybody's tired down here, too.
Yeah. How about here in Carson City? How about on the telephone? All right, we'll close public comment. I want to thank everyone. This was going to be a telephone meeting for a half an hour. Thanks for all the hard work the staff and board members have put together on this. And welcome, Scott. You got your first dunking with this one. So anyway, we will adjourn. Happy holidays to everyone. And we'll see you in January.
Thanks, Barbara.